Good afternoon, everybody. On behalf of the MOX Endocrinology Committee and our scientific partners, Science Integra, our education partners for today, Bharat Serums and Vaccines, I'm Dr. Pratik Tambe, welcoming you to this TOG webinar, which is centered on the theme of high risk pregnancy. We have today amongst us an eminent galaxy of stalwarts and faculties right across the country. And without further ado, I would like to take this opportunity to welcome all of you who have logged in as the audience, as well as to our eminent faculty from all over the country. Can we have the next slide, please? I'd like to introduce our chairpersons for today. The first chairperson is Dr. Rajendra Singh Pardesi, Vice President of EMOGS, and unfortunately, sir has had a death in the family. So I present apologies on his behalf. He will not be able to join us. Can we have the next slide, please? One of the stalwarts from the north, Dr. Archana Verma, doesn't need a formal introduction, but to introduce her briefly, she is the past secretary and president of the Ghaziabad Society, vice president Foxy North Zone elect. She'll be vice president next year. She's also been organizing secretary of UP ISAR and for midterm UPCOG, past chairperson for the Public Awareness Committee of Foxy, innumerable awards and felicitations to her credit. She is remembered for her role in conducting public awareness and health camps with the CRPF last year, and for that she was presented with an award from the CRPF as well as the Wonder Foxian Award by our president, Dr. Nandita Palshetkar. Welcome, Dr. Archana Verma, as the chairperson. Next slide, please. We have amongst us another distinguished personality, Dr. Shashwati Sanyal Chaudhary. She's been a chairperson for the Foxy Medical Education Committee way back in the past. She's a past president of the Guwahati Society, president of the ISOPAB Assam chapter, vice president elect of ISOPAB, and scientific chairperson at AICOG. Welcome, Dr. Shashwati Sanyal Chaudhary. Next slide, please. Yes, we have Dr. Rajendra Nagarkatti. I often like to call him my partner in crime because often we collaborate on many programs together. When I was chairperson for the Foxy Endocrinology Committee, it used to be with him as chairperson of the Foxy Midlife Management Committee, for which he continues until next year. He is a very distinguished obstetrician gynecologist and senior faculty practicing in the Mira Bhayandar area for more than 2 decades. He is also the chairperson of the EMOGS Midlife Management Committee and a part of the Mumbai Society office bearers as well. I'd like to thank him for being here today, joining us in spite of his busy schedule. And I think that's it with the chairpersons. Before we start today's program, it's my humble request to everybody to please keep themselves on mute unless they are speaking to avoid audiovisual issues. And before we start with the introduction of the first chairperson, of the first speaker, I'm sorry, it is customary for me to always present gratitude and greetings to our EMOGS office bearers, our president, Dr. Nandita Palchetkar, who unfortunately will not be able to join us today, and our secretary, Dr. Arun Nayak, both of whom have been pillars of support to all of us EMOGS office bearers and chairpersons, and always guiding us with their vision and their grace. Thank you so much. I'll hand over to Dr. Archana Verma to introduce the first speaker of today, Dr. Amey Purandare, who is the state coordinator of EMOGS. Sir, thank you for joining us. And without further ado, I hand over to Dr. Archana Verma.
Very good afternoon and good evening, everybody. It's my proud privilege to introduce Dr. Amey Purandare. Thank you, Dr. Pratik, so much. Dr. Amey Purandare, we all know he is the most dedicated and highly accomplished and a person with a great persona and he works best. We all saw him in 2019 with Dr. Nandita Palchekar as Joint Secretary, who was putting sweats to even the Health Minister. And Dr. Amay Purandare is a consultant obstetrician and gynecologist in Purandare Hospital, and he's at present chairperson. He was chairperson Food Drugs Medical and Surgical Equipment Committee in 2015 to 2017, and at present as he has been a member of Managing Committee and Mentor Youth Council MOX and Honorary Secretary MOX and Zonal Coordinator and State Coordinator of our MOX nowadays. So that's why the MOX will be on the world map now. So over to Dr. Amay Purandare. He'll be talking on RH immunization, which is really a preventable thing, and we need to look after what we are lacking behind. Over to Dr. Amay.
Thank you, Dr. Archana Verma, for those kind words of introduction, and really thank you so much, Dr. Pratik Tambe, for inviting me to be a part of this webinar, and all the AMOX office bearers for considering my name for one of the faculty. I will be talking today about the management of Rh negative pregnancy. Joshua Marine, one of the greatest poets, said that challenges are what makes life interesting, and overcoming them is what makes life meaningful. And Rh negative pregnancy management is one of such challenges that we face as an obstetrician. Now let us understand what is alloimmune anemias. Alloimmune anemias occur because of antibodies produced in the maternal immune system in response to the fetal red cell antigen exposure. Fetal and neonatal anemias occur because of hemolysis caused by the circulating destructive antibodies in the perinate. So initially the exposure is to the maternal immune system, and its response is to the destruction of the fetal or neonatal cells, which result in fetal or neonatal anemias. Now, why the Rh blood group system is important? In India, the incidence of Rh negative pregnancies is about 4 to 6, and strangely Spain with the Basque tribe is known to have the highest incidence of Rh negative people. Isoimmunized pregnancy, the data from US shows that it occurs only in 6.8 of 1,000 live births, and there is a decrease with the preventive measures of Rh, and there is an increase because of the other antigens, like the ones which we don't usually identify, like KEL, Duffy, MNS, KID, etc. This is a paper from North India which shows that in women who were pregnant women who were surveyed, they found that the Rh negative incidence was only 2.9, and the most common blood group was O, and the most common or the most prevalent negative pregnancy was the O negative pregnancy with the incidence of 3.9%. This was seen in about 3,000 plus pregnant women who were surveyed randomly in Uttar Pradesh. Now, a little bit about the blood group system. We all know that the most common systems are the ABO and the Rh system. The ABO system has the blood groups A, B, AB, and O. It's an antigen-based system, and the rhesus system is the one which has C, D, and E. And the D is most important. So if there is no D, we call it a small d antigen, and it represents the absence of the large D antigen. Remember, the D antigen is considered to be the most immunogenic. In other words, it is the Rh factor. How does this affect pregnancy? So if there is an Rh positive father and an Rh negative mother, and this Rh positive father is homozygous, then there is a 50% chance that the children will be Rh positive and 50% chance that negative. On the other hand, if it's a heterozygous Rh positive father and an Rh negative mother, then there is a chance the Rh negative mother is there's a chance that all the children will be Rh positive in that case. Moving on to pathophysiology, the blood cells in the fetus or the early embryo are seen to occur as early as 21 days of gestation. The Rh antigen is characterized on chromosome 1 by the 30th day. Fetal cells in maternal blood are noted as early as 10 weeks. Immunity in the mother, as I told you, the primary response is an IgM response, and it does not cross the placenta. It is the secondary response, which is an IgG response, which crosses the placenta and it produces phagocytosis through the FCYR mediated pathway at around 17 to 18 weeks. So here you see the IgG antibodies crossing the placenta, attaching themselves to the fetal RBCs via the Fc receptor, producing a phagocytic effect and causing hemolysis. Depending upon the extent of hemolysis, if there is an adequate response by the fetus, there will be increased hematopoiesis with minimal to no fetal effects, and mostly the babies get away with neonatal hyperbilirubinemia. If there is an inadequate response, it leads to extramedullary hematopoiesis, hepatosplenomegaly, and it leads to hydrops. And if there is insufficient time and a severe affection, it leads to severe anemia and intrauterine fetal death. So the antigen gets transferred via the feto-maternal route, that is, it's transplacental. Rarely you could have via the materno-fetal route as seen in the grandmother syndrome, and very rarely you could have through maternal blood transfusion if an Rh positive blood is given to an Rh negative female, or needle sharing in IV drug users. During pregnancy, during partition, the transplacental hemorrhage is seen to the extent of 50% and the volume is about 1 to 350 cc's. Antepartum is less common. It increases with trimester and the volume also increases with advancing gestational age. Various factors can enhance feto-maternal hemorrhage, ranging from spontaneous abortion, therapeutic abortion, ectopic pregnancy, chorion villus sampling, amniocentesis, chordocentesis, fetal surgeries. In 1 in 100 deliveries, there is excessive feto-maternal hemorrhage, and risk factors unfortunately identify only 50% of pregnancies which have feto-maternal hemorrhage. Now, not all women or not all fetuses get affected. And why is this? Because 1/3 or 30% are non-responders. If there is associated ABO incompatibility, it is protected. That is, A and B group fetal cells are destroyed by maternal anti-A and anti-B antibodies. In DU positive, also the response is less. If there is a small size of inoculum, it does not cause an alloimmunization, and low potency or poor efficacy of anti-D in primary stimulus requires 2.5 ml of TPH, while in secondary stimulus it requires as little as 0.1 ml of TPH. Within 6 weeks to 6 months, IgG antibodies are formed after primary exposure. These are able to cross the placenta freely and destroy the Rh positive cells. Therefore, firstborn infants with Rh positive blood type are not usually affected. The short period of first exposure of the mother to fetal RBCs is insufficient in this primary pregnancy for production of significant IgG antibodies. So the first baby does not get affected. It is subsequent pregnancies which bear the risk. As far as hemolytic disease of the newborn is concerned, as I told you, it occurs because of RBC destruction by these IgGs. It results in fetal anemia, a hematocrit of less than 30%, fetal hyperbilirubinemia. This bilirubin is neurotoxic, extramedullary erythropoiesis is stimulated, and immature erythroblasts are formed. When the red cell destruction exceeds production, severe anemia occurs. There is more demand on the extramedullary sites, and there occurs heart failure with ascites, edema, pericardial effusion. This is erythroblastosis fetalis. Hydrops occurs when the hematocrit falls below 15 and usually results in fetal death shortly before or after birth. Now, the risk and severity of sensitization response increases with each subsequent pregnancy, where there is an ABO compatible fetus with Rh positive blood. Without prophylaxis, this risk is 16% after 2 deliveries. 2% occur antepartum, 7% within 6 months of delivery, and 7% manifests early in the second pregnancy. But with prophylaxis, the risk drops to only 1%, and therefore anti-D is an extremely important therapeutic preventive strategy in managing Rh negative pregnancies. What does this risk depend on? It depends on 3 main factors: volume of transplacental hemorrhage, extent of maternal immune response, and concurrent presence of ABO incompatibility I told you it is protective, the risk drops to 2%. RH incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in future, and therefore as obstetricians we need to know about it. Now, whenever you are having such a situation, it is important to ask history for potential sensitizing events, namely abortion, threatened abortion, bleeding PV, invasive procedures, version, abdominal trauma, APH, IUFD, multiple gestations, manual removal of placenta, ectopic, and cesarean delivery. Other aspects to be included are prior blood transfusion, RH blood type of the patient and of the spouse. It must be, if there is an RH negative patient, you must ask the husband's blood group. All previous pregnancies, outcomes and interventions. Remember, the worst is if there is a history of hydrops, 90% chance that it will recur. Previous administration of anti-D, mechanism of injury in cases of maternal trauma, presence of vaginal bleeding, and a prior invasive procedure. Now, what we need to understand is that antenatal management is based on two main key strategies. One is prevention of RH isoimmunization, that is of the RH negative unsensitized woman, and the second is early detection and treatment of fetal anemia in the sensitized woman. Sensitization is determined via the indirect Coombs test, which is a screening test, also called as the antibody screening test. So if there is a woman who is RH negative and pregnant and non-sensitized, confirm the husband's blood group. If the husband is positive, do monthly ICT starting from 18 to 20 weeks. Give anti-D 300 micrograms at 28 weeks if ICT is negative. After delivery of the baby, do the blood group and BCG. If RH positive baby, give anti-D 300 micrograms to the mother within 72 hours. If risk factors for a large hemorrhage is present, do the KB test and decide the dose accordingly. During delivery, avoid methergin, early cord clamping, avoid clamp on the maternal side, and don't do MRP. So this is the protocol. Like I told you, you begin with antibody screen with ICT. If ICT is negative, post-delivery baby is positive, give anti-D to the mother within 72 hours. If you find that the ICT is unfortunately positive, manage as a sensitized pregnancy. We will talk about how we manage a sensitized pregnancy later. During delivery, don't give methergin. Manual removal, avoid. If so, do so gently. If blood transfusion is indicated, give RH negative blood only. Early clamping of umbilical cord is indicated and leave a long length of cord about 15 to 20 centimeters. Postpartum, involve the neonatologist, send cord samples for ABO, direct Coombs test, baby's hemoglobin, bilirubin, peripheral smear. If fetus is RH negative, no further intervention. If fetus is RH positive, give anti-D depending upon the dose. And this dose is determined by the 4-step lab procedure. Now, what is this 4-step lab procedure? You check for rosette fetal RBCs for feto-maternal hemorrhage. If positive, do the Claire-Beckett test based on acid elution, estimate the volume of feto-maternal RBC of hemorrhage, and calculate the dose to be given within 72 hours. So here you see negative rosette cells and a positive one with clumping of RBCs. And here is the acid elution test where you can see ghosting. The only cells that are seen are the fetal RBCs, and because they are resistant to acidic elution. Now, as far as anti-D is concerned, it is the key preventive strategy, and therefore it should be given to all RH negative unsensitized mothers, especially those who have had ectopic pregnancies, induced abortions, spontaneous abortion with potentially sensitizing events during pregnancy. And the dose generally that we give postpartum is 300 micrograms, which is enough to neutralize 300 ml of blood or 15 ml of RBCs. 500 international units is equal to 100 micrograms in some preparations where it is available. The recommendations are antenatally RCOG says give 2 doses, 28 and 34 weeks, because the half-life is 6 weeks. ACOG says give a single dose. FIGO says give a single dose at 34 weeks. ACOG says at 28 weeks. Postnatally, if the baby is RH positive, give full dose, up ideally within 72 hours, but effective up to 28 days. Identify large feto-maternal bleeds, estimate the volume, and then appropriately adequate dose to be given. 2 to remember quickly, large fetal-maternal hemorrhage is seen in traumatic deliveries, cesarean sections, manual removal of placentas, stillbirths, IUFDs, trauma, multiple pregnancy, and unexplained eye drops. We have two types of anti-D available. The older ones were polyclonal. The ones that we use now more commonly are the monoclonal ones. Monoclonal ones are genetically engineered. Unlimited supply is available. There is no risk of transmissible diseases like HIV, hepatitis B, C, etc., and can be guaranteed to have the same potency. One limitation of monoclonal and an advantage of polyclonal are that it is effective to a greater extent because it covers all the epitopes, and the risk reduction with both monoclonal and polyclonal is to a significant extent if given antenatally followed by postnatally. How does the anti-D work? The anti-D works by different mechanisms. To put it simply, it causes immune modulation, immune destruction, immune deviation, immune sensitization, and immune sequestration. This is via the maternal immune system. It's a macrophage mediated process, downregulation of specific beta cells, and it also helps in neutralizing the D antigen sites as well. So without any anti-D, there is about 16% chance of alloimmunization after 2 deliveries. The rate falls to 1 to 2% with postpartum administration, and it falls further to 0.1% with antepartum administration in the 3rd trimester. And therefore, both an anti and postpartum therapy or in administration is generally recommended. There are certain risks. There is a risk of fetal anemia, enhancement of the primary immune response, adverse obstetric outcome, reduced maternal response to postpartum rubella immunization, short and long-term harm to fetal immune system. But there is no evidence that maternal administration of anti-D results in any significant risks. It's safe and it's extremely effective. Now, I've already talked about this. We have to ensure that transmissible diseases are screened for and are not usually the preparations screened for Hep B, C, HIV, and Parvo, and the cold chain is important for ensuring adequate efficacy. Who are the candidates for anti-D? D-negative women with negative ICT who are carrying a fetus that may be or is positive, give at 28 weeks or at 34 weeks and after delivery if the baby is positive, or who have an antepartum event with risk of feto-maternal bleeding, and an Rh-negative woman who's carrying an Rh-negative fetus does not benefit from anti-D immune globulin. Don't need to give it if you know that the baby's blood group is Rh-negative. Antibody prophylaxis. In the UK, they are giving low dose also, but generally now they are recommending that at 28 and 34 weeks, you can give 300 micrograms because they feel that the half-life is 6 weeks and the response weans off, and post-delivery you give the full dose. But FIGO and ACOG have simplified it and have said that 34 weeks give the full dose and then post-delivery give the full dose as well. What about spontaneous and induced abortion? Like I told you, the D antigen is seen by 38 days, about 7.3 weeks. So in those where spontaneous or induced abortion before 20 weeks have been studied, they have found that there is 2% as compared to with an induced abortion, 5% risk of alloimmunization. And some groups do not recommend anti-D if it is before 12 weeks, but the general consensus is give it. Maybe you have to give a smaller dose. In invasive procedures, you must give it. Blunt trauma, you must give it. Ectopic pregnancy, you must give it. In threatened abortion, it is important that anti-D is administered to women with significant clinical bleeding, not just spotting, because 30% of women experience spotting, and alloimmunization in these women is rare. An incidental finding of a subchorionic hematoma on USG is not an indication for antepartum prophylaxis. Fetal death in the 2nd and 3rd trimester can be an event where massive feto-maternal hemorrhage can occur, or there could be even occult abruption. Antepartum bleeding, also there is higher chance of feto-maternal bleed with a larger volume, especially in abruption or previa. In a V mole, a complete mole does not contain fetal RBCs, but prophylaxis after evacuation is suggested in partial molar pregnancy. Also give anti-D when the type of pregnancy cannot be determined correctly. In recurrent antepartum bleeding, the recommendation is to monitor the maternal ICT every 3 weeks in women with recurrent bleeding who have received prophylaxis. If the result is positive, indicating that anti-D from the previous dose prophylaxis is still present, no treatment is necessary. If the result is negative, the woman is not yet protected. In these cases, you need to do a test to evaluate volume of fetal RBCs in maternal circulation, and you need to give a repeat dose of 300 micrograms to this patient. Special risk states: abortion 5% chance of sensitization, 50 micrograms recommended; invasive procedure the full dose, double the chance of sensitization; antepartum hemorrhage 300 micrograms stat to be repeated 12 weeks later; and in external cephalic version about 6% chance of sensitization, full dose to be given. Now let's move on to the RH sensitized pregnancy. You need to ask the patient what happened in the previous pregnancy, because severity increases in successive pregnancies, and the first intervention should be done 10 weeks before the first baby was lost or the previous IUFT. Maternal antibody estimation is with ICT titers, not just qualitative but quantitative, and fetal diagnosis of anemia is by ultrasonography, Doppler velocimetry, invasive procedures like amnio and cordo, and fetal therapy is intrauterine transfusion and IV immunoglobulin. We will also discuss the timing of delivery and neonatal care. So for a sensitized woman, management is guided by the presence or absence of history of affected fetus in the previous pregnancy. Maternal antibodies titers when there is no previous history, and sensitization may be determined by doing an antibody screen using the indirect Coombs test. The indirect Coombs test, you need to find out the maternal antiglobulin titer. The titer value is reciprocal of the last tube dilution. There is a critical titer that the lab tells you, which is associated with a significant risk of hydrops and death. Titer above the critical value is an indication for invasive testing and is useful only in the first sensitized pregnancy. Previous mild disease does not correlate with the severity of fetal disease. So here is the indirect Coombs test principle. It tells you the presence of agglutination. It tells you it is an indirect test. It checks for antibodies, while the direct test checks for the hemolytic anemia as shown as the presence of antigens. Now, moving on to an important investigation which has revolutionized the management of RH sensitized pregnancy, and that is MCA PSV or middle cerebral artery Doppler. It's made it totally non-invasive. Why? Accurate and non-invasive screening is possible with this, detecting moderate to severe fetal anemia. Sensitivity is as high as 100% with only 12% false positive rate for anemia, and has resulted in up to 80% reduction in invasive testing via amnio or cordo. Now, it's not useful before 18 weeks because the RES is too immature to hemolyze enough cells to cause significant anemia. It's not a reliable predictor after 35 weeks and is found to be similar or better than the amniotic fluid spectrometry, that is the OD optical density at 450 in the prediction of anemia. So here is how it looks, normal MCA, and here you see the spiky pattern indicating the anemic flow where hemolysis has occurred. You will find that the resistance is grossly reduced and the velocity is grossly increased. So how do you interpret? In an unaffected or mildly affected, it's normal. The Doppler should be repeated monthly, deliver at or near term after lung maturity, low risk of IUFD. In moderate affection, it is about 1.5 times MOM, repeat every 1 to 2 weekly, deliver after lung maturity, enhancement of lung maturity may be necessary. In severely affected, that is, it's more than 1.55 MOM or there is frank hydrops, prioritize the fetus to attain lung maturity and there is a high risk of IUFD. So it's a non-invasive technique first described by Mari et al. It is the blood velocity increases due to an increase in the cardiac output and decrease in the blood viscosity secondary to anemia. And why choose the MCA? Because the cerebral artery quickly responds to hypoxia. It's easily visualized with an angle of insonation close to 0 degrees and there is low intra and inter-observer variability. It can also be used, as it is seen here, in classification of the anemia and has got a high sensitivity. False positive rate is only 12%. The positive predictive value is 65%. And note, the negative predictive value is as high as 100% in this epic paper by Mari et al. Published in the NEGM in 2000. It can also be used to monitor high-risk pregnancies or pregnancies at risk. Perform the Doppler at weekly for 3 consecutive times. If the MCA PSV is less than 1.5, calculate the slope of increase between the measurements. If the slope is small, repeat at 15-day interval. If the slope is little higher, repeat at 7 days interval. If the MCA PSV is 1.5 MOM with USG findings consistent with anemia, do fetal blood sampling. If it is at least 1.5 MOM with no USG findings of anemia, repeat MCA later that day or within 24 hours to confirm elevation and then go ahead with more invasive tests. Some limitations, as I told you, it's not useful after 35 weeks, high false positive. There's no convincing explanation. It is something to do with the physics of movement. Velocity is directly proportional to pressure gradient, etc. But we really don't know, and we should not be using it after 35 weeks. Can it predict anemia after intrauterine transfusion? Yes, it is found to be also useful as shown in these 2 studies. If the MCA MOM is 1.69, it predicts severe anemia, and if it is 1.32 or less, it predicts moderate anemia. So it can be done on the day of the 3rd transfusion, and if the MOM is less than 1.5, you need to reassess after every 3 days. If it is more than 1.5, you need to go ahead with IUD. Let's look at its comparison with USG parameters. It is found to be more sensitive and specific as compared to the other parameters on ultrasound, namely the hepatic vein, the splenic vein, the liver length, etc. As compared to amniocentesis, it has got a much greater sensitivity, specificity, and accuracy, and therefore has replaced invasive testing in the management of Rh isoimmunized pregnancy. So to summarize the management, what you need to do is first do an antibody titer. If the antibody titer is beyond the critical level, you reach 34 weeks and deliver immediately. If you have not reached 34 weeks, enhance the lung maturity, do an MCA PSV. If it shows that the MCA PSV shows MOM of greater than 1.5 or there is high drops, you will have to go for amniocentesis or you will have to go for chordocentesis and then treat the baby with either intrauterine transfusion or deliver the baby. So here you see, this is the flowchart on how you manage. Remember, on chordocentesis, if you find that the hematocrit is less than 30, you need to deliver. If it is more than 30, you wait till 35 weeks. These are some of the signs of fetal hydrops: pleural effusion, ascites, scalp edema, etc. There is an ultrasound score ranging from placental changes to all these signs like ascites, effusion, anasarca, and a poor biophysical scoring. There is progression of hydrops, and therefore the role of ultrasound is that in the absence of hydrops, no USG findings could distinguish mild from severe hemolytic disease, although morphologic USG findings fairly specific for the evidence of fetal decompensation, their absence doesn't rule out significant fetal anemia. Now, other non-invasive testing as we use as clinicians are the fetal movement count, absent breathing movements, abnormalities in NST, the classic sinusoidal pattern which is ominous, late decelerations, but all these are late signs, and fetal ECG changes have also been documented. When do we go ahead with invasive testing? When there is history of hydropic stillbirth, fetal transfusions, neonatal exchange transfusions, the maternal serology has crossed the critical titer or there's a sudden rise in titer, and on fetal examination, you find suspicious features such as a rising AC, placental edema, ascites, or hydrops. Two main techniques. One is amniocentesis. The second is chordocentesis. Amniocentesis looks at the amniotic fluid optical density to indirect evidence of bilirubin in the amniotic fluid, while the chordocentesis directly evaluates fetal blood sampling, checking for the fetal hemoglobin levels. We all know that it is depending upon the degree of amniotic fluid bilirubin, which is directly proportional to the degree of hemolysis, but this can be at times wrongly denoted if there is contamination by blood, meconium, exposure to light, passage of the needle through the placenta. You have the classic Liley's and the Quinan's charts to tell us the degree of hemolysis. The Liley's is not accurate before 26 weeks, but the Quinan can be used from 14th to 40th week and has a sensitivity 10% superior to the Liley's chart. The chordocentesis is an important test. When we do chordocentesis, we obtain cord blood, which is sent for blood group, DCT and reticulocyte. There is a fetal loss rate of about less than 2%, and complications include intraamniotic bleeding, exsanguination, bradycardia, cord tamponade, and may worsen alloimmunization. So indications are when there is an increase in the OD 450, there is evidence of hydrops, or there is fetal anemia documented on chordocentesis as HCT is or hematocrit is less than 30%. What's the definitive treatment? Intrauterine transfusion. To put it simply, it's the transfusion of the fetus with maternal compatible packed RBCs. There are two routes, intraperitoneal route and intravascular route. Intraperitoneal cannot be used for hydropic fetuses. Intravascular route is the one which is usually preferred in those cases. So it is recommended for severe fetal hemolytic anemia in utero, carried out between 18 to 35 weeks, maybe intraperitoneal or intravascular. You give Rh negative packed cells with a hematocrit of more than 80%, and the amount transfused is calculated by this formula depending upon the gestational age. The intravascular transfusion is done under high resolution ultrasound. Preferably the umbilical vessels the needle is inserted close to the placenta, which is the primary target. If that is not obtained, then you use the others. The fetal heart may be used as a last resort in critically ill patients where no other site is accessible. When do you plan the next transfusion? Remember, the rate of fall of hematocrit is about 1% per day. Unpredictable between the first and second transfusions. After 2 or 3 transfusions, the fall is constant. The next intrauterine transfusion should be planned when the hematocrit falls to the critical level of 20 to 25%. Important point is that timing of delivery should be done after the last transfusion is done at 34 to 35 weeks and induced labor at 37 to 38 weeks. Complications, fetal loss rate of about 0.6 to 4%, transient fetal bradycardia, cord accidents like hematoma, disruption of the vessel, spasm, bleeding from the puncture site, preterm labor, PPROM, and increased risk of feto-maternal hemorrhage. Intraperitoneal transfusion was described by Liley. Disadvantage is that I told you it can't be used when there is hydrops or ascites. Pre and post transfusion hematocrit cannot be sampled. There may be trauma to the abdominal organs, and increased intraperitoneal pressure can compromise venous return, resulting in fetal bradycardia. It's mainly dependent upon the absorption by the lymphatics. But the advantage is that it can be used before 20 weeks where chordocentesis may be difficult, where access to the cord may be improbable, and may be combined with both intravascular transfusion, as it allows increased volume to be transfused without overloading the circulation. So to put it simply, we do an MCA PSV, determine the degree of anemia. Depending upon the degree of anemia, either we continue monitoring with MCA PSV or we do invasive procedures like chordocentesis or amniocentesis. What's the outcome? Overall survival rate of fetuses with hydrops is about 80%. Mild hydrops may be as high as 98%. Severe hydrops as low as 55%. So hydrops is an important poor prognostic sign. Intrauterine reversal of hydrops is noted in about 65% of patients where hydrops was present. After reversal of hydrops, almost all fetuses survive, and therefore you must attempt to reverse the hydrops and must give the baby a fair chance. Persistent hydrops outcome is unfavorable with a survival rate of less than 40% for all fetuses and in less than 25% of severely hydropic fetuses. So the average outcome in various studies for hydropic fetuses is about 70 to 88%. Once the baby is born, how do you manage the neonate? The cord blood sample should be taken at birth and sent for PCV, DCT, bilirubin, peripheral smear, and blood group. 2 hours of age, bilirubin is repeated. If the cord bili is more than 5 or the PCV is less than 35 or there is a rising bilirubin, you need to do an exchange transfusion. If no exchange transfusion is not given, IV immunoglobulin is given. Bilirubin is to be repeated 6 hourly and decide whether there is need for exchange transfusion or phototherapies. These babies should receive phenobarbital on day 1, followed by a dose, lesser dose on day 4, and after discharge follow with hemoglobin and PCV once in 15 days till 6 weeks of life. Postpartum, the baby should be admitted in NICU. Urgent exchange transfusion is indicated in moderate to severely affected neonates. If the baby is mildly affected, it will get away with phototherapy. Other treatment modalities include plasmapheresis, where there is less antibody titer. If there was a previous IUFD at less than 20 weeks, with more than 20 weeks, remove 2 to 3 liters of plasma 2 to 5 times weekly. IV immunoglobulin, it suppresses the maternal antibodies, decrease placental transport, and fetal reticuloendothelial blockade. Dose is 1 kg weekly, and however it has high cost. The important thing is that it delays anemia and decreases the need of intrauterine transfusion. Some recent advances: non-invasive fetal genotyping from fetal cell-free DNA in maternal circulation is being done. Point of care tests, which are rapid tests for determining RH status. Lower dose preparation for use in first trimester is being evaluated, and the concept of partial D and weak D antigens usually test positive but can also form anti-D antibodies has been described. What are the challenges according to me in RH negative pregnancy in our country? The high cost of immunoglobulin, the lack of resources to adequately investigate and monitor fetuses in utero, the low turnout for antenatal clinics, so you have missed cases, poor documentation of prior sensitizing events, and loss of case notes. So to conclude, friends, every woman of childbearing age should have her ABO and RH typing done. Obtain ABO and RH types of the husband of women who are RH negative. Ensure ICT is done at 20, 24 and 28 weeks of pregnancy with appropriate prophylaxis. At times, a single postpartum dose may be inadequate in cases of severe fetomaternal hemorrhage. For women who are RH negative, whose fetus is or may be D positive, routine administration of anti-D should be given early in the 3rd trimester. The optimal dose is 300 micrograms to be repeated when postpartum if the baby is RH positive. Additional dose may be required if there is a larger dose of a larger volume of fetomaternal hemorrhage. Testing for quantifying fetomaternal bleed is better done for events after 20 weeks. Repeat doses for those where repeat bleeding episodes and better be decided by ICT after 3 weeks. Remember, anti-D should be given within 72 hours after delivery of the RH positive infant. If it is missed out, please give it as soon as you remember it, because partial protection is still afforded within 13 days of birth and may be effective as late as even 28 days after birth. Friends, RH isoimmunization is an obstetric complication and all efforts need to be made to mitigate its impact. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of the newborn remain. Great advances have been made in the detection and management of this condition, and hence many of our RH negative pregnant women today can have better fetal outcomes. As I end, I dedicate my talk to these 5 gentlemen: Landsteiner, who described the ABO blood group system; Weiner, who described the RH system; Levine, who first identified the anti-D antibody; Liley, who got in amniocentesis as fetal therapy; and Mari, who has made it possible to make invasive testing into non-invasive testing by the innovation of MCA PSV in managing sensitized pregnancies. I end my talk by the saying by Sir Alexander Fleming, the inventor of penicillin, who said that medical science has proven time and again that when resources are provided, great progress in the treatment, cure and prevention of disease can occur. Probably he was talking about RH isoimmunization when he said this statement as he received Nobel Prize. Thank you all for a patient hearing, and thank you so much, the organizers and the chairpersons, for giving me the chance to be with you this afternoon.
Thank you, Dr. Amay Purandare, for a fantastic and brilliant oration. I think we've rarely heard anybody speak about RH isoimmunization in such a fantastic manner. Can we have the grid view back on? I think there are a couple of questions from the audience which we can take before we go to the next speaker. I think Dr. Archana Verma has one question and Dr. Nagarkatti has another question.
Dr. Nagarkat, Dr. Amay Purandare, this how why in the India we are still lacking the primary prevention so much. There's still RH isoimmunization, though it is looking like very easy step. But why are still isoimmunization going on?
I think the reason is because twofold. One is that antenatal prophylaxis is still not universally done in India, maybe because of the cost. And also, as far as the detection is concerned, we are not wholeheartedly going and detecting, looking for isoimmunization. As far as sensitized pregnancies are concerned, we do lack still in fetal medicine or fetal therapeutic units which are dedicated for such complex cases.
But still, I think that if we do it awareness at a first level and we don't go to the secondary level and let all the sensitization, if still hum us line ko hi break.
So I appeal to you, Dr. Archana Verma, that when you take over as Foxy Vice President, because it is your forte to do public awareness, you please also concentrate on RH isoimmunization, not just cancer prevention, not just infection prevention.
Very true, Dr. Amay Purandare. Actually, the keeping the injection is also very important कि कैसे रखना है और कितना देना है और how much and at what time. मतलब majority of the rural public में जो आशा and workers हैं उनको RH grouping and injection antenatal prophylaxis, if we tell, it is not very costly, definitely not very costly. Okay. Now Dr.
With the polyclonal anti-Ds, it was very costly, but now with the monoclonal antibodies, the preparations which are available, there is a substantial reduction in the cost now.
Amay, I have one question. If you get a ICT positive in a primary, absolute primary, where she's not had any abortions or any previous pregnancy, what could be the cause? And secondly, in such a patient, if the sonography is normal, there is no hydrops, then what would you do? Is a repeat titer after some days the next thing to do?
Yeah, so if you get an ICT which is positive in a primary gravida, it could be rarely a grandmother syndrome where it is being passed down the generation, or perhaps it was some sensitization which was not clinically identified by the patient. Now, as a clinician, you want to know the significance of this ICT positivity. ICT positivity is a qualitative test. You want to quantify it. So you do a quantitative titer, you find out whether this titer is significant or not. Okay, if it is not significant, then you repeat the titer and see the trend, whether it is upwards or downwards. If it is a downward titer, that means it must have not been a significant titer. You manage her in the absence of eye drops and the management and the absence of any Doppler signs. If it is a positive titer which is critical, then in that case you have to unfortunately manage her as a sensitized pregnancy. Probably, unfortunately, the sensitization has occurred, and now you will have to deal with a more aggressive fetal approach, fetal management approach.
And Dr. Rajendra Katti, so many times patients never tell about the empty pill or abortion in the previous history.
Actually, an ART
questions from the audience. If we can move ahead, there are two quick questions from the audience for the speaker. The first is from Dr. Sabita Agarwal.
I just want to give one comment.
Yes, ma'am.
Yes, ma'am.
Just a comment. Just a comment is that because we work in medical college, we have seen that the number of RH sensitization has come down drastically. If you say it in last 6 months, we hardly got any such type of cases because our government, they give free of cost this isoimmunization. They do this anti-D prophylaxis for the patients. They don't get it antenatal, but sometimes, but postnatal, they get it routinely in the hospital once they are hospitalized, the indoor patients. So that is why probably that incidence has RH isoimmunization has come down. Thank you. It is an extensive.
that's why, Shashwati ma'am, it's come down from 16% to less than 2%. So there is almost a 10%, 10 times drop. If we want this to come even lower, we will have to give antenatal. But like you rightly said, universal postnatal prophylaxis is available at no rate. It's free of cost in the government sector, but antenatal prophylaxis is still not subsidized by the government.
So with the permission of the chairpersons, I'm going to take the liberty of asking two audience questions to the speaker. Dr.
Pratik, I can't hear you clearly.
Dr. Sabita Agarwal is asking, after giving injection at 28 weeks, whether second injection is to be given at term or after delivery.
Yeah, so when this prophylaxis schedule was first developed, their first regimen was to give it at 28 weeks, 24 weeks, and then repeat it post delivery. Here the dose was less, 150 micrograms at 28 weeks, 150 microgram at 34 weeks, and then 300 micrograms. Subsequently, they realized that 150 is too less, so let's give 300. Then they went on to say, now what is recommended is give one antenatal at 34 weeks and one postnatal after delivery. Most of the earlier studies talked about its efficacy in the second pregnancy, not in the index pregnancy. That I strongly believe that it would be more useful in the second pregnancy as compared to the first pregnancy. But global agencies do recommend and global organizations do recommend giving it even in the index pregnancy.
Thank you. And one final question. This is from Dr. Lakshmi Renuka, and she is asking whether antenatal prophylaxis is 150 IU or 300 IU.
I said the recent recommendations are 300 IU.
Thank you, sir. Thank you so much. If there are no closing remarks from the chairpersons, we'll go to the next speaker, Dr. Professor Pratap Kumar. And for his introduction, I hand over to the chairpersons.
Thank you, Dr. Pratik. Wonderful talk by Dr. Amaya. As you rightly said, he's covered the topic so beautifully. And moving ahead, we have the next speaker. He is going to be speaking on the do's and don'ts of the pre-evaluation tests or predicting tests for preeclampsia. As we all know, preeclampsia is a condition which causes so many vascular events and changes in the pregnancy, and it can have adverse effects on the fetal and maternal well-being. And therefore, to be able to predict it and, if possible, prevent it or at least control it adequately would be something which will really help the well-being of the pregnancy, the health and the well-being of the fetus and also the mother. So therefore, to discuss these various predictive tests, with which one to do, which one not to do, and which has more value, we have none other than the very, very knowledgeable, very intelligent, I would say an encyclopedia of knowledge, none other than the well-known Dr. Pratap Kumar to discuss this. So, and everyone knows him, but it is my proud privilege to read out his CV. He is the National Vice President of the FOXI for the year 1999, Inspector, Examiner and Advisor of the National Board of Examinations, Examiner of undergraduate and postgraduate students in several universities, appointed on the editorial committee of several journals, President Karnataka State Obstetric and Gynecological Society, the KSOG, in 2011 to 12, member of the Task Force of Human Development and Disease Biology, Department of Biotechnology, New Delhi, member of the Project Review Group, PRG on Reproductive and Child Health, ICMR, Delhi. He's got numerous awards, most important of them being the Dr. Durusha Lifetime Achievement Award in 2017 by the ISAR. He's won the Fertivision 2018 Leading Lights Award, the FOXI Dr. Kutti Lifetime Achievement Award in 2011, the Dr. D.K. Tank Reproductive Health Care Promotion Trophy, has more than 300 publications and presentations and more than 800 presentations in national and international journals. He's editor of 10 books and contributed to several chapters. You are, sir, welcome, and it would be an honor to listen to you, sir. Over to you, sir.
Thank you very much, Dr. Nagarkatti, for having introduced me. Pratik Tambe, special thanks for having invited me to share my experiences on preeclampsia, prediction and prevention, do's and don'ts. I bring greetings from Manipal Academy of Higher Education, Manipal in Karnataka state. Now we all know what is preeclampsia, there is no doubt about that. I wouldn't waste time on defining because everybody knows, and incidence also we know around 1.5%. Now, everybody knows maternal mortality, one of the causes eclampsia. I'm not going to talk about that. And we all know eclampsia can kill a woman with so many kinds of problems of different systems, but everybody knows once again. Now, when we know that the huge number of people die of severe preeclampsia and its complication, we should know how to really prevent it. Now, the unmet medical need, the gold standard for diagnosis of preeclampsia relies on proteinuria from many, many years. It has changed now. Once is a proteinuria means you've already gone into the higher stage of preeclampsia. Now, poor prediction might lead to unnecessary hospitalization, and some women who will go on to develop preeclampsia may be overlooked. Now, the only treatment for preeclampsia is delivery. We should know that point. Nothing works well. So preeclampsia remains the most common reason for iatrogenic delivery. And of course, because of that, spontaneous preterm. There has been an unmet need for a reliable method for the diagnosis and short-term prediction of preeclampsia and for assessing the risk of preterm delivery. Now, the earlier thinking was, we thought it's unpredictable. It's a multi-organ disorder, very unique to human being. It's a common, dangerous, and poorly understood condition. That's what we thought long back. But now things have changed. If we can actually, little more understanding has come into the medical knowledge and can be changed in the modern way to a certain extent. I think you should predict it quite well. Now, we all know about uterine artery. The fetal medicine people have established how to take uterine artery Doppler. And the uterine artery Doppler, when it is narrowed, uterine artery Dopplers will change because it supplies the uterus. Now, the etiology of preeclampsia is failure of trophoblastic invasion to the spiral arteries of the myometrium. So when the baby grows and the placenta grows, that should kind of invade the uterine, the end arteries there. Hence, you'll find the cytotrophoblast is also called as extravillous cytotrophoblast. It also the villous component. Now look at the left side, there'll be proliferation, migration, invasion. The right side of the square will be fusion and syncytial trophoblast. But the picture you will understand very clearly. The cytotrophoblast is the green one, which goes beyond the vessel and gets into the the area, the decidua itself. So obviously, this kind of cytotrophoblastic invasion is also called as extravillous trophoblast. It's beyond the villus, that's called extravillous trophoblast. So if the extravillous trophoblast, as you see on the right side, it kind of dilates the vessel. If there's a penetration of the extravillous trophoblast, the dilatation occurs. That means the spiral arteries will get dilated, the uterine artery gets dilated. So what do we understand by that? When we know that this villi can dilate a vessel, that's a good point. If it doesn't happen, there's a poor spiral artery remodeling is frequently cited as the initiating feature of preeclampsia. So if the trophoblast invasion does not occur into the vessel, it will remain normal or even small. It will be narrow. If it invades, there will be dilatation. So we know that if the uterine artery is narrow, that means there will be uterine artery pulsatility will pick up some kind of a problem. So we want in all pregnancies dilatation of the vessel. In preeclampsia, it does not occur. But when it occurs, it's a terrible thing to happen. I always tell my students, if there's a severe preeclampsia or even before that, all the organs connected will have vasoconstriction. It's not only uterine artery, all over the body there'll be vasoconstriction, maybe except the brain. Hemorrhage and necrosis. That's when the liver, placental bed, there always be hemorrhage and necrosis. That is why we teach undergraduates saying severe preeclampsia means epigastric pain, blurring of vision. All that is late sign. That means it is all occurring because of vasoconstriction, hemorrhage, and necrosis. I'm not going to talk about that today. I'm only going to talk about what the science has developed now. A uterine artery Doppler has to be carefully done identified uterine artery. I'm not going to the technique of Doppler because a lot of time is needed for that. How to do it, please get trained how to do it. But I'm just going to tell you the science behind why we are doing that. So uterine artery Doppler is done on both sides. If you get a good flow, we know it's a safe condition. But what my colleagues started telling me was, in the 12 weeks for the recommendation initially, they all said it is so small, it is very difficult to get uterine artery unless you're a fetal medicine person. But everybody is not a fetal medicine person. So when the fetal medicine people can identify it very easily, the general Doppler people, it may be difficult. So are we really should we do at all is my question in all pregnancies. Now the companies came out with these kind of biomarkers. We got little confused initially. We thought everybody should get this done. So releases, whenever there's ischemia, I told you about the vascular problems, the placental ischemia occurs, it releases placental factor from the placenta called as SFLT1. That means thyrosin kinase. It's a protein, basically it's a protein called SFLT. Now this protein gets into the vasculature and it reduces the basically that protein reduces the vascular endothelial growth factor, means it is not too good. Now with the placenta, that means the vascular constriction occurs. So whenever there's SFLT more, the vascular constriction occurs because the protein will reduce the vascular endothelial growth factor. We all know the VEGF will increase in certain pregnancies and the dilatation occurs. But if the protein comes there, it will not allow the dilatation. Now the placenta also kind of has another growth factor. Whenever there's ischemia of the placenta, this growth factor is reduced, which is needed for placental early growth. So you can understand by that, one protein comes out and it causes vascular damage. The other one, placenta, doesn't produce the growth factor, and the placental also doesn't do the job well. So there are two problems here. All these problems will lead to endothelial dysfunction. So if you look at this diagram, the first one is vasodilation, the bottom one is the vasoconstriction. Now all these, the green ones are all VEGF, the blue ones are the placental growth factors, and the little bit of arc ones, the moon shaped one, the UU shaped one are SFLT. If SFLT, the second one, you'll find too much of SFLT is there compared to the above diagram. All these will kind of get stuck there and the vasculature definitely changes. So inflammatory disorder, diffuse endothelial dysfunction, impact trophoblast cell invasion of the spiral arteries. It means in these kind of preeclampsia, they'll be increasing the SFLT1, that the protein increases, and the free placental-like growth factor decreases. So the upward trend of SFLT and the downward trend of placental growth factor are together. It's a deadly combination. They cause vascular constriction. Now, another thing is, interestingly, at 12 weeks, you'll find people are doing the Down syndrome screening. I always tell people that Down syndrome, yes, but also look at the PAP-A. Because the PAP-A, placental associated plasma protein, comes from the placenta. If the placenta is ischemic, it doesn't come out well. That means if the levels are less than 0.5 multiple of median, that woman will get into preeclampsia and IUGR. So it's not only for Down syndrome screening. Watch the MOM. If it's 1.5 is fine. If it's less than 0.4 MOM, multiple of median, you should be alerted. That patient will get into troubles. So I've also told you about the other two, which just now. Now, one interesting point is the National Health Services of UK said you can at least measure mean arterial pressure. We were doing it long back when we were students and we forgot about it. Now again, their thinking is, why don't you do mean arterial pressure at around 12 weeks? So the mean arterial pressure defined as the average pressure in a patient's arteries during one cardiac cycle. It is considered a better indicator of perfusion to vital organs than just the systolic and diastolic blood pressure. It's very easy. Diastolic blood pressure multiplied by 2. You add systolic blood pressure divided by 3. I repeat, diastolic into 2 plus systolic blood pressure divided by 3 is about less than 110. So 70 to 110 is an ideal mean arterial pressure. And it's not easy to do this. It's not so easy at all. I will tell you how people are expecting to do this. That's what they say. You put that BP cuff, and in fact, both arms you have to take, and the position of sitting, back supported, legs uncrossed, arms at the level of the heart, and reading at least 2 readings in each arm. So it's not an easy job. If everybody, the 100 patients are waiting in outpatient, it's very, very difficult to do for all these patients. I think if you know that there's a high risk candidate, I think you can start doing it. But the recommendation is to do mean arterial pressure, at least if you don't do the other test. Let's go on. So whatever I said now, the risk factors I think is important. Who are the people? Should we do more about this? Should we do more is whenever they have age factor, weight factor, racial origin, and the previous pregnancy history, and if her mother has had some preeclampsia, conception by assisted reproductive technology, chronic hypertension, diabetes, SLE. That means if there's a history before and in the pregnancy, they all come under high risk. I think in those kind of history, you start doing mean arterial pressure at least, if you cannot do the other ones. So, but looking at the last red line there, all this mean arterial pressure, uterine artery pulsatility, and pleasant factor, what the bottommost red line there, is never 100%. It is only the detection rate, maybe 77% to positive rates are not very high. That means it is never 100% diagnosis. So the Fetal Medicine Foundation UK also did a huge study, and they said prediction of preterm eclampsia. And here also they said the screen positives are picked up by these kind of issues. But look at what is written in red. Just see the red ones there. Is nothing is 100%. It's 75%, 80%, and so on. It is never beyond 80%. That means if you put all these parameters, you might predict about 80% of the time, yet she may still get preeclampsia. So all these tests are never saying it is 100%. Now, should we do all these tests at all was my doubt. So I really read about it for this particular talk and given this talk a little earlier once again. In fact, I discussed with the UK system also, and what I understood was in all the fetal medicine unit, they will do all this. They will do uterine artery Doppler, they will do this PAPI, they will do PLG, FPL, all the what I said till now will be done in all fetal medicine unit. That means it is still detection rate is 74%. So remember, fetal medicine people are experts in that. But what about the general population, general obstetrician? I'm talking to the general obstetricians because if you have a doubt, your fetal medicine person is next to you, you can always send them. So what has happened is always a doubt. But I always once again repeat by saying, do not ignore PAPI when we send the same for down screening because the less than 0.4 or 0.5 MOM is abnormal. Now this has been told. Now the Fetal Medicine Foundation said by history, look at that, history is so important. Our postgraduates don't realize history is important. I think history taking is an art. History, mean arterial pressure, uterine artery pulse index, and the PLGF, the NICE guidelines also said the same. If you do all this very early in pregnancy, a big number, 90% of them may be detected. It's later on the pregnancy detection becomes slightly less. Now, so they said if there is resistance of uterine artery Doppler, give 150 milligram of aspirin at night. It's not 75, it is 150 milligram, but you must start at 12 weeks. That means if there's a past history of problem, present problem, and mean arterial pressure is going wrong, uterine artery is going wrong, all those markers are going wrong, then you give 150 milligram of aspirin. But my question to everybody is the same. Now, fetal medicine scoring people have clearly said there's a huge prevention of preeclampsia by this. They did all these 11 to 13 week scan. They did screen positive, means 1 in 100. All what I said, if it's positive, becomes screen positive. And these people were put into placebo or aspirin, and they found aspirin studies really proved to be very good. That means it prevents preeclampsia. Long back, the class study and so on kept on telling it didn't work because they were giving 75 milligram. So it is not the point. We should give 150 milligram at bedtime. So there's a huge reduction of preeclampsia by 89% if you do all this by 12 weeks, 82% by 34 weeks, and 62% by 37 weeks. What does it tell you? Almost 95% reduction at term. So if you really are smart enough to pick up by 12 weeks, you can reduce by 95% preeclampsia, but never 100%. So, beneficial effect of aspirin that was started at or before 16 weeks. It's important. Don't start beyond that because the trophoblast invasion occurs, which I've been talking to you a little while ago, is basically happened by 16 weeks and afterwards it doesn't really matter. So you cannot start at 16 weeks. You must start before. If at all you start aspirin of 150 milligram, please start before 16 weeks, but the best is 12 weeks. So the inversion of pyramid care has occurred in 2018. 12 weeks seems to be the most crucial ultrasound, and you go on making less and less of ultrasound later and do a birth plan. Now, my colleague asked me, then why not give aspirin like iron and calcium for everybody? Why should we have a headache at all? So there are two reasons, because the better compliance if we identify high risk and we explain to them that it would be beneficial for them to take aspirin. Aspirin may increase risk of hemorrhagic problems, and treating a lot of people may have a major adverse effect. It is rational that we should screen, identify the high-risk group where aspirin would certainly be beneficial, and emphasize to those women with a high compliance. So we are not going everybody. You just have to choose them and give. Now, once again, all these companies came and said, do this test and that test. And all the fetal medicine people said, do uterine artery. So I got confused, and how do we do for everybody who's pregnant is not possible. So I am going to tell you now, the fetal medicine people will definitely do, there's no doubt. If it's done, it's the best. But how many people can have access to fetal medicine? We are here as a general obstetrician and gynecologist for the whole country. So should we do all these tests, what I discussed just now? So what I did was I read about this. March 2009, you can Google this. It's a very interesting article. It's called a Saving Babies' Lives, version 2 of National Health Services of UK. I did discuss with Dr. Mandeep Singh, who's our friend from Mumbai and working in UK as a consultant. I had a half an hour discussion with him. And he said in fetal medicine department, they do all that. But the general UK, they don't do. So I'm only going to talk about the general one, because that UK system seems to be interesting for the general population when there is no risk at all. So this updated element recognizes that uterine artery Doppler screening for high-risk pregnancies can improve efficiency by targeting scan resources. There's no doubt about that. We cannot push it away. But the simplified approach of deciding, do we need to do all the tests like Doppler, biochemical tests for 100 out of 100 patients? What tests can we do in our clinical practice, and for whom? How do we choose these kind of tests? We have a large experience of tests, but we should test correctly. And who should get aspirin? I think at my stage of my career, I should be telling others, do not do too many tests. You pick up tests, what is necessary, what is not necessary, and give the patient the best of advice. Suppose there's low risk means the first young pregnancy, no problem, no history at all, she comes under low risk. In those low risk pregnancy, there is no need to do uterine artery Doppler at NT scan. If you do, well and good. Nobody says don't do. But I'm saying during NT scan, you don't have to take another half an hour to do uterine artery. There is no need to do biochemical markers. So can add uterine artery Doppler at the anomaly scan time. And the third trimester routine checks, keep on doing them. And long back we were measuring the fundal height. We are still palpating and forgetting the measuring tape. They have brought back the measuring tape again and said, measure the tape, measure the fundal height, and don't forget the simple technique. So I repeat what I said. A young patient, no problem in this pregnancy, mother also fine, grandmother fine, everybody is fine. No history at all. In those patients, easy. Just do the NT scan and send them off. There is no need to do any of these tests. But if you have a fetal medicine, somebody wants to get tested, I'm not saying don't do it. Do it, that's all. But otherwise, generally not necessary. So when there's a moderate risk, look at that. First, look at the last line, the red line. Consider aspirin if the woman has 2 or more. If there are 2 problems, like the first pregnancy is a problem, but low risk, but she's 40 years. That means you must give aspirin. Pregnancy more than 10 years. Did you realize that? The last child is 12 years and they're delivering now. Above 10 years, it's a high risk case. You can't ignore them. Body mass index of high body mass index. And of course, family history of preeclampsia in the first degree relative like sister, mother. and multiple pregnancy. So I read again, there's a moderate risk of any of these. There are two problems. Start aspirin. There's no need to test. Don't do all those biochemical tests. Just start 150 aspirin. It's very becomes easy. Now the high risk case, look at the bottom line, the red line. Recommended aspirin if there's even one problem. So when there are high risk pregnancy of hypertension, chronic kidney disease, autoimmune diseases, diabetes, hypertension, and some placenta showed some last time some problem. So remember, if there is a chronic medical illness, even one of that, please remember, start aspirin by 12 weeks. So very easy, I simplified the whole thing for you. Low risk, nothing much to be done. Moderate risk and high risk, you start aspirin. In moderate risk, there are two conditions, you start aspirin. High risk pregnancy, one condition. I think you should Google, all the young ones who are listening to us right now, postgraduates, it's a big question for in the exam. And even the elder ones who are listening, please choose the investigation for your patients. But definitely if there's somebody having absolute contraindication, you can't be forcing on that to her, like hypersensitivity to other salicylates, etc., and the known problems. The relative contraindications are gastrointestinal bleeding, active peptic ulcer disease, gastrointestinal genitourinary bleeding, hepatic dysfunction. So please remember, sometimes you don't even take this history and you tell them to swallow aspirin. She's a known case going into gastroenterology all the time. Peptic ulcer disease patient, which we have missed the history, but many times patients do tell us the history themselves. So the risk assessment and screening in the second trimester, in the early, whenever there's preeclampsia, there will be IUGR. Fetal growth restriction is rare, but that time if you pick up the uterine artery once again, second trimester, there is no recommendation to do. If you find the growth is the less than the 10th percentile in the second trimester, that baby will get into IUGR and that mother will get into preeclampsia. So IUGR, fetal growth restriction, may be the earlier part of preeclampsia, but at that time you can't start aspirin. But observe, if you do the 10th percentile growth in the 18-week scan, then you have to keep frequently do it. You have to do every 2 weeks till at least 34 weeks of pregnancy, the scan. So the risk assessment in the second trimester, for women with normal uterine artery Doppler, the risk of these disorders is low, and thus a serial scanning of the biometry can be recommended in the third trimester. That means if the second trimester scan shows some growth problem, we are talking about preeclampsia, but I'm also adding on because both are connected, preeclampsia and FGR. If you have a doubt, I think you should keep calling them every 2 weeks to check for the blood pressure, check for the growth, and so on. So this is once again a simplified version. I'm going to summarize by saying the March 2019 Saving Babies' Lives version is very interesting. Low risk factor means no risk factor, means no other test nor any treatment needed. You do the anomaly scan. If the baby is more than the 10th percentile, no problem. Just keep calling up for routine checkup, but keep measuring the fundal height, and you can do by maybe 32 weeks at least one scan. If the semifirst fundal height is less, it should be every 2 weeks. If there's a moderate and a high risk cases, you would assess the placental dysfunction by the uterine artery Doppler. Aspirin will be started, and you keep calling her by 28 weeks. UK says 32 weeks, but I think I would recommend 28 weeks. If there's a problem in the second trimester or the first trimester, start calling them by 28 weeks, every 2 weeks till you deliver them. The high-risk pregnancy, start aspirin at 16 weeks. Before that, additional uterine artery Doppler, same thing. The same thing I said, 10th percentile growth, all that I've covered, I'm repeating it again. But these are all late signs. We've been teaching students forever, lot of edema, ring getting stuck there. They're all late. That means they missed the bus. Too much of edema should not have occurred at all. You should have started aspirin much before time. Sudden weight gain, there are late signs. You cannot say it's not put under prediction. That means they already have preeclampsia. They're all late signs. So the New England Journal published another one. The last part of couple of minutes, I will tell you about the role of the protein which came out from the placenta, SFLT, and the placental growth factor in women with suspected preeclampsia. What do they mean? Supposing there's a patient at 32 weeks, 140/90. and the protein is negative. That means you don't think it is preeclampsia, but don't ignore her also. So 140/90, see if there's proteinuria, there's no doubt it is preeclampsia. But what the recommendation is, if you have a case of 140/90, you just have to do this ratio. I will tell you what the point is. The ratio is important because I think I will tell you this here. The ratio in the management of suspected preeclampsia, the key recommendation is SFLT, placental-like growth factor, is an aid for the diagnosis of preeclampsia. It should not be used in admitting patients, nor used to decide the timing of delivery. What does it mean? You simply don't go on taking for everybody and don't admit 140/90 for all the reason. If you think it's 140/90 after 6 hours of rest, you may not even need admission. But do this ratio. Look at that. If the ratio and the risk of developing preeclampsia in the next 7 days, that means today is one date, next 7 days, she will get preeclampsia. The ratio is more than 85. Look at that. The SFLT, placental-like growth factor ratio, more than 85 means half of them will get preeclampsia in 1 week. But if it's less than 38, it's a low risk, and it is usually next 3 weeks also nothing may happen, or even a 1 month nothing may happen. The risk is 0.4%. However, we will still call them and check for blood pressure. So I repeat again, the ratio of SFLT, that's the protein coming from the placenta, and the placental growth factor, and the risk of developing preeclampsia in the next 7 days is very low if it's 38. It is very high if it is 85. So remember that value, because that can predict preeclampsia. That patient has to be called back. And that's the beauty of this ratio. The NICE guidelines, I just emphasize, it's a little older one. It's the same story. High risk pregnancy, moderate risk pregnancy, and the detection rates are the same. Now looking at that, if you look at the current practice, what many people are following is this, is the most ineffective. They're waiting for the blood pressure to go up. They're waiting for the urine to come out. They're waiting for the weight to go up. They're all very inefficient way of managing. So early preeclampsia is completely missed. If you look at this age-old teaching, the BP, weight, and urine dip is age-old. That means she's already got preeclampsia. I have been talking the last few minutes on prediction and not what happens with preeclampsia. I'm not going to tell you how to manage preeclampsia. To summarize, careful history of previous problem and the present problem is very necessary. Have a checklist. When you go for shopping, you'll say, one, check, 1, 2, 3 for 10 things. You tick those 10. Just exactly like that. In your antenatal clinic, have all this checklist. You can keep ticking that. Categorize to low risk or not. If low risk, no need of uterine artery Doppler, nor any biochemical test, unless you are in the fetal medicine unit, which can do it. Fetal growth at anomaly, if it's more than the 10th percentile, you are reassured, either for FGR or for preeclampsia. If other risk factors assess more with uterine artery Doppler and biochemical factors, you would do that more definitely, and start aspirin of 150 milligram by 16 weeks of pregnancy in those moderate and high risk pregnancy. And later in pregnancy, there's a rise of BP, proteinuria is always there. Without proteinuria, do that ratio. It's quite expensive now, it's not routinely done. We just started doing for some time back only. Do the ratio and predict when she'll get preeclampsia. To conclude, preeclampsia can be predicted by taking multiple parameters apart from a good history of the past and the present pregnancy. Choose the right investigations for the right pregnant woman. The right to survive pregnancy and childbirth is a basic human right. Thanks to Foxy and the MOX for inviting me for this. And of course, thanks to all of you. I'm pleased to know that a big number are registered today. I think it's more than that number what I put there. And thank you once again, all of you.
Thank you, sir, for that beautiful talk on the predictors of preeclampsia. You've made it so practical and lucid for everyone that I think everyone will take home a good message today. That particular point of the placenta, the placental probe, the PAP-A, the MOM of less than 0.5 or 0.4 is so very important, because normally we just see the double marker report, and most of the gynecologists, generally obstetricians, they generally just see the values, low risk,
Yeah.
And but that is not the only thing. Down syndrome is not the only thing. We need to look at the PAPE values also. And also you made it very easy to when to start aspirin. Sir, just one question. Is it standardized today that you start 150 milligrams for all?
Yes, 150 milligram for all. That because there are a huge number of cases have been studied. They actually analyze all the 75 milligram one. That's why the class study said it doesn't prevent eclampsia, but we know it is preventing the severity. But now it's always 150 milligram. But please remember, if somebody cannot tolerate that, you don't have to give it. You can give a smaller dose, but the 75 milligram has been studied extensively. And the 150 milligram has been chosen after huge amount of study by the UK group, where our friend Mandeep Singh is there in that group. That is why he is the one. I had a half an hour discussion just last month about this, and he kept telling about how fetal medicine people do, how the other people should do, and things like that.
So, but in those cases who are having a gastric problem like gastritis, and if they are tolerating 75, then is it also useful to continue that dose?
No, I think you have to weigh the balance because she cannot tolerate what else to do. You just have to give 75 and keep quiet about it. Yeah.
Right. Sir. Okay, sir. Okay. Thank you, sir. Yeah. Yes, Aswati madam.
Yes, Dr. Pratap, it was always a pleasure to hear you. Such a fantastic presentation. And those high risk and low risk, those points are so important for these postgraduate students. I just want to know about whether you have any idea on the new thing that molecule has come for the prediction of severity, or whether she is going to develop preeclampsia, is a glycosylated fibronectin. Any inputs from your side?
Yeah, there are a lot of studies which has come on the glycosylated fibronectin. It is still experimental, and it has not been as a generalized National Health Services in UK at all, nor in America. It's all experimental, and I think that still on the research end of it, we cannot be taken. We are not able to get a very positive result about that because we haven't really done the randomized control trials at the moment.
I just want to tell that we have done a study here in our medical college.
Have you published that?
We have found there is a very strong correlation because it's a point of care. You get the result then and there. You have a small slides where you put that you have to take a small amount of blood with a micro pipette and that you result get then and there. And we have seen that there is a strong correlation between if the level goes beyond 600. Then the chances of development of preeclampsia and the abnormal fetal, the maternal fetal outcome we have seen. We have not seen that whether from the beginning, but we have taken those patients who have already developed preeclampsia because they have
you are correlated people are all with preeclampsia.
Yeah, with the background.
I think if you publish the data, it will be good because to get the study, to get 10 patients of preeclampsia, you should get 100 patients. 10% only the incidence. So really, you want to study the huge number, you should do 10,000 cases to really say it's effective.
Of course. We have done only 60 cases, I think.
Yeah, it's not
that big. But it was really, really fantastic. And this PLGF and your S-rate, it is not easy to get in everywhere. PLGF included in the studies where they have given the first trimester marker.
Correct. It's not easy, but certain of these biomarkers are available in certain institutions. I think it just becomes a research unit there itself. It's not for public use.
Yeah. Thank you so much.
Shashwati madam, may I
tell.
Shashwati madam, what marker did you use in your trial?
Yes, what?
What marker did you use in your trial?
That is glycosylated fibronectin. It is a test that is,
Okay.
Thank you, Professor Pratap Kumar. I think that was a fantastic.
Pratik, you are not audible.
I'm not audible?
No, not so good.
Volume is very low, Pratik.
Yeah, volume. Increase your volume.
Better now?
Yeah.
Can you hear me much better now?
Better, yeah.
Okay. Better. So then I'll speak without the earphones since I think there's some glitch.
Yeah. Now.
It's always a pleasure to listen to Professor Pratap Kumar because he's so evidence-based, systematic, and he brings all the latest things to us. It's always a privilege to listen to him. And I think more than anything else, those of us who are removed from teaching, who are in private practice really appreciate talks like him. There's one small question, sir, from the audience. I don't know how relevant it is. This is from Dr. Ranjana Jha, and she's asking, can aspirin be given when SGOT, SGPT, or there is a high bilirubin level? Would you advocate its use in such patients?
No, that's what I said in my talk. There are any other medical conditions, you cannot be starting aspirin. Because
Absolutely,
if everything goes to the liver, it is a common sense. If something is wrong, if you don't start something new, you get into problems. Yeah.
Thank you, sir. There are more than 600 people logged in today to listen to two of our excellent speakers, Dr. Amey Purandare and Professor Pratap Kumar. If we were in a physical conference, I think we would all stand and applaud you for 1 minute. But unfortunately, we are in a webinar. So I think you'll have to be content with our gratitude and our thanks. My thanks are also due to the chairpersons. If there are any closing remarks from them before we move to the panel discussion, I would request them to please give them to us.
Jitendra Sharma has come in, so
You can applaud from here on.
Yes, that we can do.
thank you so much. It was my pleasure to be with you all, and all the best.
Thank you.
Thank you, sir. Thank you so much. So without further ado, I think we'll move to the panel discussion since we are already running late. Can I request for the presentation of the CVs to be put up, please, so that we can formally introduce all the panelists? So welcome to all our panelists. Our panel is on labor room emergencies. There's nothing new really, but what I want is a perspective from people from different parts of the country on how they practice, how they tackle these emergencies. We have a mix of both junior and senior colleagues from different parts of the country, those who are going to be talking about the medical college perspective, people who are going to be talking about private practice. And we have amongst us, of course, Dr. Jitendra Sharma, who is a medico-legal expert who brings his own different sort of approach to all these emergencies. To start the ball rolling, we have Dr. Rekha Rajesh. She is the Joint Secretary. Can I have the slide up, please? Because we need to introduce the panelists. Backend team. So Dr. Rekha Rajesh is the life member of multiple organizations. She is the Joint Secretary of IMA Hosur. She is the Honorary Secretary of the Society of Krishnagiri. She holds a diploma in reproductive medicine and a postgraduate diploma from London as well as Germany. She is an FICOG with another diploma in cosmetic gynecology. Welcome to our panel, madam, and we look forward to hearing from you. Our second panelist is Dr. Indranil Datta. He is an associate professor from Durgapur. He is zone coordinator under the president of FOXI for 2020 and 2021. Past president of the Kalyani Society, has multiple publications and presentations in various different publications as well as presentations at conferences, bestowed with numerous and innumerable awards, as you can see, too long to list, and we welcome Indranil. Next slide, please. Dr. Pradnya Changede is an assistant professor at Sion Hospital in Mumbai. She is the assistant secretary of the Journal of Obstetrics and Gynecology of India, which is the official FOXI journal. She's an MUHS recognized postgraduate undergraduate teacher and a member of the Youth Council of the Mumbai Society. Of course, she is well published and known as a very good teacher in Mumbai. We welcome Dr. Pradnya Changede. Next slide, please. Dr. Priyankur Roy is the other half of the combine of Indranil Datta. I think wherever Indranil is there, Priyankur is not too far behind. He has multiple awards to his credit, including the Foxy Corion Award. He has also delivered the Kamini Rao Oration, recipient of the Leela Krishnamurthy Memorial Award, multiple presentations and publications. He has a diploma in infertility and advanced gynecendoscopy from Germany, and he is a consultant in infertility and endoscopic surgery at Shiliguri. Next slide, please. Our next panelist is Dr. Aruna Suman. She's an associate professor at the Osmania Medical College, and she's currently the vice president of OGSH, that is the Obstetric and Gynecological Society of Hyderabad in Telangana. Unofficially, she is known as the right hand of our president-elect, Dr. Shanta Kumari, and we welcome Dr. Aruna Suman. Our next panelist is Dr. Ritu Sinha. She is a senior consultant from the Department of OBGYN in Dwarka Hospital in Prayagraj. She's been trained in gynecological endoscopy at AIIMS in Delhi, trained in colposcopy and preventive oncology at SMC in Lucknow. She's a past treasurer of the Allahabad Society in 2017 and 18, organizing committee member at several conferences, and we welcome Dr. Ritu Sinha to this panel discussion. And finally, at the end of the day, we have our medical legal expert, Dr. Gitendra Sharma, who is a practicing obstetrician gynecologist in Ahmedabad since nearly 30 years, published several books, given more than 1,500 lectures all over India, chairperson of the Ethics and Medical Legal Committee of FOXY, president of the Ahmedabad Society, and so many other distinguished awards to his credit. We welcome Professor Dr. Gitendra Sharma. If I may be allowed to share my screen, we would like to start with the panel since we already are quite late. So today's panel is on labor room emergencies.
Pratik sir, just wanted to...
Yeah, go ahead.
Pratik sir, yeah, just wanted to inform you, Indranil, his actually in-laws yesterday tested for COVID and it's come positive. So we have to leave and he's gone back to Durgapur basically. So he just wanted me to inform you. He was there for during when Pratap sir was talking, but then he said that he had to leave because he was getting late and they have to go and get them admitted. So
all right, we present apologies on Professor Indranil Datta's behalf, but I think we have enough panelists and we'll have a very fruitful discussion. I like to always start with a quotation, and I think this is particularly apt when we think about emergencies in the labor room, when a few minutes delay can make the difference between life and death for a laboring mother. And I quote here Sir William Osler, "The best preparation for tomorrow is to do today's work superbly well." So if we try and think about these cases as actual patients that we are dealing with today in front of us, then hopefully we will be able to tackle these emergencies much better when they come to us during clinical practice. The first case I would like to direct towards two of our panelists, Dr. Rekha Rajesh from Hosur and Dr. Ritu Sinha from Allahabad. This is a 25-year-old lady. She is married since 2 years. She's a primigravida with 34 weeks pregnancy. Antenatal course is uneventful. She's had 5 visits. All the routine tests have been done. Ultrasound is within normal limits. But at 34 weeks, she is brought to accident and emergency by relatives. There is a history of a generalized tonic-clonic convulsion lasting for about 1 minute. She is in a post-ictal state, not actively convulsing now. What I would like to ask my eminent panelists is, how would you manage this patient and what are the key issues at stake? Dr. Aruna Suman and Dr. Ritu Sinha.
Good afternoon, sir. Thank you for introducing me in such kind words, sir. So whenever, regarding this case, sir, I would say whenever a patient who is pregnant and presents with generalized tonic-clonic convulsion, the most likely diagnosis is eclampsia, otherwise, unless it is proven otherwise. So this patient with 34 weeks of pregnancy has landed up in emergency. So it should be treated as an obstetric emergency only. So when the patient comes, shift this patient immediately to the intensive care unit. And since emergency cannot be dealt all alone, so we should call at least 3 to 4 persons for help. And I'll ask one of my staff to get the eclampsia tray ready. Now, as an emergency, I would first like to support the patient's ABC. That is, the A stands for the airway, B is the breathing, and C is the circulation. So here, first of all, I will make the patient lay down in lateral decubitus position, and since the patient is in post-ictal phase, so I will also like to put her the side rails up so that she might not injure herself. Now, airway should be put in, and oral all the secretions to it, they are to be sucked out. Now, uh, 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 now start supplementing oxygen. Now check for the I'll put the indwelling. I will put the indwelling catheter. One of my staff. I'll ask one of my staff to put the indwelling catheter, and fluid should be started from one arm. At the rate of ringer lactate is the fluid which we can start at the rate of 125 ml or so. Meanwhile, I'll and the main aim here now is to control the convulsions. So I'll start the loading dose of magnesium sulfate to the patient. Magnesium sulfate is given in the dose of magnesium sulfate is given in the dose of 14 grams as loading dose, with 4 grams to be given as intravenous bolus dose, followed by 10 milligram intramuscular, 5 milligram in each buttock. This has to be followed by a maintenance dose of 5 grams in each buttock every 5 hourly. Now, I'll check the blood pressure. If it is more than 150 or upon 110, then I'll give the labetalol as IV bolus injection of 20 milligram, and watch for the blood pressure for in another 20 minutes. If the blood pressure still remains the same and the desired result is not coming, then we can repeat the dose of 40 milligram and then 80 milligram every 15 to 20 minutes, depending, until the result is there. Meanwhile, I will send the investigations, blood investigations of the patient, which includes the complete blood picture that will tell us about the platelet count of the patient, liver function test including SGOT and SGPT, the kidney function test, which includes the creatinine, blood urea nitrogen, uric acid, and the serum LDH levels.
Thank you, ma'am. I think you've covered a lot of ground. Let's go over everything systematically one by one. I'd like to ask Dr. Aruna Suman, madam, that what do you think is the ideal anticonvulsant in pregnancy? Some people like to use diazepam. If you consult your internal medicine colleagues, they often say phenytoin should be given. Somebody else will recommend a third thing. But what do you think is evidence-based, safe, effective for use by us OBGYNs in everyday practice?
So the safest drug, the anticonvulsant that we can use is magnesium sulfate. There is lot of evidence regarding this drug which decreases the morbidity and mortality in eclampsia patient. Actually, the best regimen is Pitcher's regimen. In our institution, we use Pitcher's regimen, which is easy and which doesn't really need the biochemical level, or the therapeutic level need not be monitored, and we can clinically monitor it. Every 4 hours it should be repeated. If there are every 4 hours before repeating, we have to check for the patellar reflexes. We have to check for the respiratory rate. It should be more than 16. And we have to check for the urinary output. It should be at least 30 ml per hour or 100 ml per 4 hours. So I think magnesium sulfate is the best drug that we can use.
So as you can see, there was a MAGPIE trial in 1995, and 25 years later, also endorsed by Cochrane, 15 trials, more than 10,000 women, shows very clearly that magnesium sulfate more than halves the risk of eclampsia. And in patients with eclampsia, even today, the age-old drug still is the first choice. There is a reduction in the occurrence of maternal death, and it also reduces the incidence of serial maternal morbidity. Coming to the regimens, as Madam pointed out, we like to favor certain regimens, and I would like to ask Dr. Rekha Rajesh here, what is your preferred regimen for use in eclamptic patients?
In my practice, we are implementing the Zospan regimen, where we use 4 grams with 20% as the loading dose, and follow up with 1 gram per hour with the same 20% dilution. and for the next 24 hours, monitoring knee-jerk urine output and the patient. Depending, and in this patient, the response would be ideal for with the Zospan regime because IV continuous bolus will be there for the patient without a gap of 4 hours. So that
Dr.
we
Aruna
can
Suman
establish the
prefers
baby.
the Pritchard regimen. Dr. Rekha Rajesh prefers the Juspan regimen. Both of them are in close physical proximity to each other. One is in Telangana, one is in Karnataka. There is already a controversy in the first 10 minutes. Can somebody tell me which regimen is recommended by WHO? Question is open to everybody. Dr. Pragna Changede, as a member of the journal, what would you endorse? What are you practicing in Sion Hospital?
In Sion Hospital, we are practicing the Pritchard regimen. We give a 4-gram IV loading dose along with 5 grams in each buttock. That is a 14 grams total loading dose. And what I would like to emphasize here is also division of the duty, or like when a patient comes, everybody shouldn't be running helter-skelter and finding the same thing. So, proper drills which should be frequently happening. In Sion Hospital, we actually don't need a drill because we keep on getting that many eclamptics. But for nursing home or a smaller setup, I would recommend regular drills so that each person knows that if a patient comes who is supposed to load the magnesium sulfate, who is supposed to catheterize, who is supposed to take an IV, take the collections.
Absolutely.
So I think dividing the duties and each one knowing their role will help manage the patient in a better way.
So 25, 30 years back, I'll give you my personal example. When I was a resident, this concept of, in inverted commas, obstetric skill drills did not exist. But being the first poster, I was always the person who cut the ampules, made sure that the correct dilution was there, the right strength, whether it was 25% or 50%, those ampules were maintained properly, that the expiry was not over. All those things I had to look after personally. Of course, now I don't do that anymore. That is now delegated to other members. But as rightly pointed out by Pradnya, that each person in the team should not behave like a headless chicken and run around in circles. They need to have their own designated roles, and everybody should swing into action in such a way that they help each other and not get in each other's way. I think Priyankur wants to say something. Yes, sir.
Yeah, sir. If you're talking about a WHO, I think WHO recommends the Zuspan regimen, the IV regimen basically. I mean, I was in CMC Vellore in 2008-9 when the study was going on about the Zuspan versus the Pritchard regimen, and that time Zuspan was quite an effective thing. Only thing that has to be made sure in this study while we are giving the intravenous thing is that the drip rate should be fine. I mean, we should not try to, there are places where the place is overloaded and very busy, and the sister just comes and, just opens the stopcock and goes away, and the maxilla goes on in a flow. So other than that, I think Zuspan regimen is perfect if you are giving it at 1 gram per hour, given over 24 hours, because it saves us the painful injections and also the chances of getting those abscesses in the back where the injections are given.
But in our institution, at given point of time, we have almost 12 to 19 cases of eclampsia at a given point of time. We have used Pritchard regimen with all our postgraduates available, with all our duty doctors, and we have been successful. And we didn't have any problems till now.
Yes, ma'am.
So to look at the evidence as it stands,
every institute can, form protocols for themselves, which was best in the given situation.
Correct. So and if we look at the evidence as to whether magnesium sulfate is being used at all in India, I have this paper which was published in 2018, which looks at 2 districts from Karnataka in India, and these are primary health center level facilities where 88 facilities were reviewed. A lot of them were in the private sector. They found that magnesium sulfate was available in 60% PHCs, 100% of taluka and district hospitals. Both the recommended strengths, 25 and 50%, were available, but the usage was quite low. 23% of the personnel were not using magnesium sulfate. Leave alone our controversy today whether we should be using Pritchard or Zuspan in preference. People were actually not using it, and 14% of the district and primary health center level workers were not using it even in eclampsia. So I think what is key to reach out is to talk to district level providers, primary health level workers, and let them know that this is a life-saving drug. All of us need to be trained in its usage and we should be using it. Which particular regimen one uses has to be as per the institutional policy as rightly pointed out, but then there have to be obstetric drills, there has to be key messages which percolate down to that level, because often us working in tertiary institutions are not the people who will be the primary providers who will look after women with eclampsia. This message has to reach out to the smaller towns and cities. A very important question that we need to address is that there are standard regimens accepted in international journals and teaching like Pritchard and Zuspan, but there are some alternative regimens also available which use low doses of magnesium sulfate because of fear of respiratory depression. I'd like to ask Priyankur here, what is your experience with these alternative low dose regimens? Have you used them? Are they effective? Do you recommend them?
Sir, not really. I mean, the uses that I have done is with magnesium sulfate. Initially, we had started off with the Pichard regimen, but then after I have started with the Zuspan, I do use Zuspan only. I haven't used much of the lower dose regimens because what I feel is the regimen Pichard Zuspan is here after a lot of studies and after a lot of tests, and I've never found any problem with them. So I prefer using them as well itself, sir. I do not go for a low dose regimen.
Thank you, Priyankur. I think there are some small scattered studies which have shown in a few limited patients that low dose regimens may also be effective, but still we don't have large population studies which recommend their use in routine daily practice. So until further notice, I am sure Dr. Gitendra Sharma will also agree with me that from medical legal point of view and for your own personal protection, we stick to what is written in our standard textbooks. Would you agree, sir?
Definitely, sir. But one thing is there that whenever your standard book gives 2-3 things, so that means where 2 or 3 schools of thoughts are available. So if you are following any one of them, you cannot be held negligent for the same. So you can follow Pritchard regime, you can follow Zuspan, you can follow Sibai's regime or any other regime, which is mentioned in a booklet or your any journal or in WHO guideline or in standard textbook. So wherever it is mentioned. So if some school of thought is available, you can follow anyone.
I think we'll go to the next case and
Sir?
this one.
Sir, please.
Yes, please, ma'am.
Sir, we have one more thing for prevention. I think that we can talk about the gustosis scoring, which is very good. Foxy GCPR is released in 2019.
Correct.
This is a very good scoring system, especially in preventing the morbidity and mortality.
Absolutely. So I was one of the team along with Professor Alpesh Gandhi, Suchitra Pandit, Gorak Mandrukar and Girija Wak, who was part of that committee where we did under Dr. Nandita Palchetkar's leadership this Foxy GCPR on identification and prevention of hypertensive disease in pregnancy.
At
but
the
that is
basic
more
level.
for prevention, and that was released at the ICOG conference in Bhubaneswar last year. It's there on the website. It's also there on my website. But here, since we are discussing labor room emergencies, I have not put up those slides.
Okay, right.
I have concentrated and focused more on management of active eclampsia.
As that is a good scoring, I thought I should mention.
Absolutely. Yes, ma'am.
Here in Tamil Nadu, sir, we have trained all the PHC and VHN staff regarding the management with magnesium sulfate and primary management in the PHCs. So I think that way we are doing a little bit of a better job over here. Identifying early also has been happening, and we see a lot of improvement and early referrals do happen.
Thank you so much.
Well, I would just like to add one thing.
Yes, sir.
Though I am right now in West Bengal practicing here, but I've done my undergraduate and postgraduate training in the South, in Tamil Nadu and Karnataka. But I will say even in the rural centers in those places, it's very well managed. Even the basic of primary health centers have magnesium sulfate, and I believe me, they have those ambulances which I think 888 or 999, which on call they come and they pick the patients up from a PHC, and even the ambulances carry magnesium sulfate. I was shifting a patient from a primary center to CMC main hospital, and the ambulance had a magnesium sulfate which we had to give because the patient had a fit in the ambulance itself. So it's really very worth mentioning.
That's
And
great
NHM
news.
is conducting many drills, eclampsia drills, to create awareness.
Thank you. Thank you. Let's quickly
Thank you.
move to the second case. This is a 35-year-old. She is diagnosed with gestational diabetes. On insulin treatment since 26 weeks. Fortunately, is well controlled. Has presented at 38 weeks in active labor, 5 centimeters dilatation in the middle of the night. Last ultrasound report 1 week back shows an estimated baby weight of 3.5 kg. She has come to Sion Hospital. Dr. Pradnya Changede is the consultant on call. What would be the issues that you anticipate in this patient, madam, when she is in active labor in the middle of the night? Most of us are sleeping peacefully, and sometimes even the residents are asleep, and the resident on call themselves are called by the nurse who is delivering the baby when they encounter difficulty.
Yes, sir. So actually, I would like to say Sion Hospital residents don't sleep. So they will be wide
It was
awake.
not meant as a personal remark.
No, not personally, but I
Apologies.
would say being a busy hospital, I'm sure all of them are on their toes. And of course, since she's come in active labor, I would expect a pelvic adequacy to be done here if it has not been done at term. Since she is diabetic, and also there is a scan which is showing 3.5 kg. And in diabetics, we know as the week progresses, the baby weight is going to increase. So here we expect that we assess the pelvis as she is in active labor, and of course we can give her a trial if the contractions are good and the pelvic adequacy is there. I would like to point out that since she is diabetic, it can be a macrosomic baby. So even if the fetal head comes out, you can expect that there may be chances of shoulder dystocia. So the residents have to be very well trained in dealing if there is a case of shoulder dystocia. So, a wide liberal episiotomy will have to be given. The patient becomes fully dilated. Of course, they are very prone to have stillbirths also, FSBs. So, strict monitoring of the fetal heart sounds during labor. Also, the maternal well-being, that is her glucose has to be monitored well, because as we know, if in the in the pregnancy, if the sugars are high, the neonate is prone to go in hypoglycemia. So initial blood glucose screening has to be done, and depending on that, we have to decide what type of IV fluids we have to give her. So usually when a diabetic goes in labor, we start neutralizing drip, which includes a 5% DNS with 5 units of insulin, and her HGT is monitored, and depending on the sliding scale, we adjust the dose of insulin. So the ideal target is to maintain the blood glucose value of between 70 to 110. That has been recommended. So anything which is not in this range has to be corrected. If it is on the lower side, you start a dextrose point, and if it goes above that, then we have to put insulin. So that can be given by short-acting insulin other than the sliding scale. And of course, one has to be ready for any non-progress or any arrest in the labor, delayed descent, or even as I said, shoulder dystocia. So the drill has to be ready. Again, the residents have to be well versed in delivering.
So the
Thank you, ma'am.
partogram
So
is
I
a
think
must.
a lot of things which you have covered are already there in the NICE guideline on management of gestational diabetes. This was published in February of 2015 and has been recently updated in 2018. ACOG also has practice guidelines on gestational diabetes, and we will not be talking so much about the antenatal management of diabetes here. What I want to focus on is the obstetric emergency of shoulder dystocia. What is classically said is that when you're anticipating dystocia, it never happens.
Yes.
It usually happens when you least expect it in a low risk patient. And though classically we have been taught that it is more common in diabetics and infants of diabetic mothers, sometimes it can happen even in a non-diabetic patient where the pelvic adequacy, thank you for pointing that out, has not been assessed or has been incorrectly seen. So can you just guide us quickly through what are the different steps which we should be taking to tackle shoulder dystocia if it does occur?
So I think the first step is anticipating and being ready for it. I think nothing can beat that. But of course, if you're faced with an inadvertent situation where you're least expecting and it does occur, is everybody should again be well versed with what is to be done. First is you call for help. Even before you start doing any maneuvers, is you call for help, because to do all those you're going to need help from assistant. And first thing what we teach is, you see, if you've given an episiotomy, if you've not given, you can give. The most important is you don't pull the head, because you have to understand the problem is way above, and just pulling on the fetal head and is not going to solve the problem. So there are maneuvers in, first, you can try the suprapubic pressure and the Mac Roberts maneuver, in which you will flex the hips on the abdomen and you will abduct and then bring them on the chest, and that will increase the angle of inclination, pelvic inclination, and along with the suprapubic pressure we can help deliver a baby. If it doesn't happen, then there are other maneuvers serially. There is a Woods corkscrew maneuver, there is delivery of the posterior arm, there are Rubin's maneuver 1, 2, and last but not the least, the Gaskins or the all four maneuver. And frankly speaking, there is also description of the Zavanelli maneuver, but it's very difficult to do. They are, I think, theoretically you should be knowing, but mostly I think delivery of the posterior, Mac Roberts and delivery of the posterior arm usually helps relieve shoulder dystocia.
Thank you, ma'am. Dr. Aruna Suman, anything further you would like to add? Any tips for success?
If you are diagnosing shoulder dystocia, you should never pull it. It will cause lot of problem. Brachial plexus injury is very, very common. And you should not apply fundal pressure. This is also contraindicated. You should never do it in the labor room. So identification is very important. Even in a diabetes woman, this is a patient of diabetes, but it is under well control. But even with the normal sized baby, it can happen because of the fat in the shoulder blades. So you have to suspect and you have to be ready, but you can never prevent it and predict it. So in this condition, it is better we be ready with that helper. Mnemonic should be remembered. And initially we have to try. 90% of the women will deliver with Mac Roberts maneuver and suprapubic pressure. In our institution, mostly we are able to deliver by these two maneuvers, Mac Roberts maneuver and suprapubic pressure.
Thank you, ma'am. Dr. Gitendra Sharma, sir, as a medico-legal expert, I think this is an ideal case for you. If you look at Western countries, almost 70 to 80% of their litigation, obstetric litigation, is because of two reasons. One is because of instrumental delivery, and the second is because of brachial plexus injury. Fortunately, that has not yet caught on in India, but maybe in the next 10-20 years, we will be facing the same issues. Can you give us some tips to handle this situation?
Basically, the basic of law says that you have to follow the standard guidelines. So standard guidelines in India says that any baby who is above 4 kg, then you should not deliver it vaginally. And predicting shoulder dystocia, you should deliver it from by cesarean section. Second thing, we get many cases of shoulder dystocia. So we can easily defend them. Because one thing that we can say that nobody can predict shoulder dystocia, because it can happen even in 2.5 kg baby, and it may not happen even at 4 kg baby. So it is unpredictable thing. Second thing, that there are cases which are known that even on cesarean section, the brachial palsy has happened to the babies. So we cannot assure that by doing delivery by cesarean section, we can avoid 100% the brachial plexus injury. And third thing, that whenever two schools of thoughts are available, you can follow any one of that. So that means whenever there are two options, that either to go for vaginal delivery or to go for cesarean, you can follow any one of them. So these are the things. And recently one case decided by National Commission, and in that case, Dr. Singhal's case, it was in Delhi. And in that case, it was said that documentation is very much important. She delivered a baby, developed shoulder dystocia. Later on, baby developed brachial palsy. So in that particular case, the delivery note, she didn't mention that she applied the Mac Roberts maneuver. And for not writing that in the delivery note, she was given compensation against her, about around 30 lakhs rupees compensation is awarded against that gynecologist. That why didn't you mention Mac Roberts maneuver? So that means you have not applied it. So be sure regarding your documentation, and whenever you document anything, you should document it properly in your delivery note, that what different kinds of maneuver you have tried at the time of delivery to avoid this palsy or injuries to the patient.
Thank you so much, sir. I think those are words of wisdom. And in any obstetric incident, ensuring proper documentation in the right format and preserving a checklist like this, which is given out by ACOG. There's also one by the RCOG. It's part of the guideline. I think will go a long way towards ensuring that none of the points which require documentation are missed by us. Usually in the aftermath of any such incident, all of us are behaving at a spinal level. We forget basic things to write, like date and time when we have actually examined the patient. So starting from that and ensuring that there is a proper protocol and a checklist like the one given by ACOG and RCOG should be adopted. It should be part of the standard teaching also for our postgraduate students, and ensure that our nursing staff are also following the appropriate guidelines with appropriate training and skill drills happening periodically. Let's quickly move to the next case. This is a 30-year-old. She's married since 4 years. She's tried infertility treatment, got bored and discontinued after a few months, then conceived spontaneously. Later on during pregnancy, she gives a family history of insulin-dependent diabetes, uneventful antenatal course. Patient herself did not have any IDDM or GDM. Screening is normal. At 37 weeks, she comes in spontaneous labor, 3 centimeters. The junior resident has done an ARM. There is blood-stained liquor and a pulsatile structure is palpable. Dr. Priyankur Roy, you are the consultant on call. What are the steps that you take next?
Okay, so first of all, at 3 centimeter, I do not advocate amniotomy, which should ideally not be done. Because the thing is, once a patient goes into the active stage of labor, which is right now to be taken at 6 centimeters, for me, I would consider, considering the history, that this is a case where amniotomy has been done when the head may be or may not be engaged, or the other thing could have been that if the head has been engaged, it was a case of a cord presentation which was missed. So what has happened is basically could be, since you are also saying that there's been a family history of diabetes and we do not know what exactly was a sugar as per the history. So there could be two things over here. One could be a vessel running over the membrane is a condition in which we call it as a vasa previa, which has been while doing amniotomy that has been ruptured, and it could lead to bloodstained liquor. So we need to note one thing, that in case that has happened, then it's an absolute emergency condition, because the blood loss is the loss from the fetus, and an emergency at that point of time, an emergency cesarean section has to be planned and taken for. The second thing that could have happened is in case the liquor was excessive, or it was a case of a bit of a poly, and we have gone ahead and done a rupture of the membrane. So the thing is that has happened is because head was not engaged, and so obviously the cord has slipped out because it could be a cord presentation or the head was not engaged. And the other thing that could have happened is also a bit of a placental separation or abruption due to sudden decompression because of the amniotomy that was done at 3 centimeters. So in that sort of a scenario, if the cord has come out, it is a case of a cord prolapse basically. So basically, I will have to, if I am in the hospital, of course, the consultant in the hospital, I immediately run to the labor room, and then the thing is, ask the OT to prepare the OT and plan for a cesarean section. But while I'm preparing for the cesarean section as well, it's very important that the cord that is hanging out, you should not try to push back the cord into the uterus, because it's very difficult to push it back because it can lead to further compression. So a wet gauze piece which is wrapped around the cord and kept it in the vagina holds good, because the thing is, only thing that we have to prepare is a spasm, because if the cord is lying outside and there's compression between the cervix and the head, that itself can cause decrease in the blood flow and fetal asphyxia. But if we leave it in the vagina in a gauze piece, wrapped in a gauze piece, then that does not cause any change in the temperature, and there's no spasm in the cord, and the blood flow to the fetus is normal. take the patient to the OT as soon as possible. And ideally, the baby out time from the time of cord prolapse should not be more than 20 minutes.
And
So
we can
try
fill
and
the
take
bladder at this time. We can fill the bladder with 500 to
Yes.
700 ml of,
yes. So
Yes.
that, and
so that
also
it
the
won't
knee,
cause compression.
correct. Also the
Also,
knee
give a
elbow
head tilt
position
to the
can be
patient.
tried.
This position is.
Yes,
Tendon
knee
elbow.
elbow position can be tried
Yes,
where,
yes.
yes, settlement
That's
position where
somewhat
it can, the
clumsy.
cord can slip back. But sir, I think if we can quickly shift the patient to the OT and we have a minimal time difference of 15 to 20 minutes, I think it's best not to, try all positions, etc., which can lead to further spasm and decrease the blood flow to the baby. Quickly shift the patient to the OT and take out the baby as soon as possible without much handling of the cord.
Thank you. Thank you. I think that is eminently and beautifully covered. All the different points have been addressed. The incidence of visa previa and placenta previa, which gets uncovered at amniotomy. I think at large institutions where you are having more than 10-15,000 deliveries a year, you will encounter at least one patient like this in 6 months or 12 months. And this is a nice article which I found on amniotomy and cord prolapse. There are very few of these, but this is published in 2013. There are 2 trials from Turkey, and they say that there is 1 cord prolapse occurring every 300 patients. So typically, whenever we train our residents, we always tell them to fix the head or have an assistant to fix the head while the amniotomy is being performed. Ideally, it has to be done in a setup where everything is ready, the nursing staff is there on standby. You don't do it in the receiving room quietly and then give the patient an enema and then send her to the labor ward, which sometimes residents can do. And this is another paper which I found which showed that out of almost 2 million deliveries, there were 369 cases, which is the largest published case series, more associated with multiple pregnancy, non-vertex presentation, preterm labor, of course, and a spontaneous rupture of membranes, which may occur at term or preterm. The key, as Priyankur pointed out, is to diagnose it in time, inform the entire team, ensure that there is less compression as far as possible in the delivery to diagnosis period. And my residents and my lecturer always used to tell me, sir, we have only 5 minutes to deliver this baby. More than 5 minutes, we'll probably lose this child. And sometimes the nursing staff used to be reluctant to open the OT and get everything ready. And then we used to tell them, cord prolapse, we have to do it ASAP. Let's go to the next case.
Sir, I think you're insisting for a general anesthesia is also important. So that the patient's position is not changed in the hand inside.
Yes, that's also a very good point. Thank you, Dr. Pradnya.
Also, teaching a controlled amniotomy is very important, like in a high station.
Very good.
Ideally, you should not do, but if you have to do, suppose sometimes it just doesn't fix. So then, using a spinal needle or, just creating a small opening and controlled drainage of the liquor can prevent abruption as well as cord prolapse.
Especially where you're suspecting that there may be a polyhydramnios or there may even be an undiagnosed polyhydramnios.
Yes. And one more important thing is after you rupture the membranes, insist on listening to the fetal heart sounds after.
Yes.
And also the hand in the vagina should confirm after rupture the presentation. So I think
and before amniotomy, I think the presentation should be identified. No, if it's a breach or a transverse line or something. So before amniotomy, it should have been identified and then planned.
Perfect. So this is a 30-year-old. She's presented in active labor. She's progressed well on the partogram. Baby weight on the last ultrasound is about 3.2 kilograms, which was 1 week ago. At full dilatation, despite the best efforts, good contractions, after 45 minutes, the station is still -1 to 0. It's still very high. It's too high to apply a vacuum. It's even higher for a forceps delivery. I'm going to ask Dr. Rekha Rajesh, what do you think is wrong with this patient? Everything was progressing well until she reached the second stage of labor. How do we tackle this patient?
So we now need to reassess the presenting position of the baby. And maybe they have not ruled out CPD, or you need an intrapartum ultrasound to understand the position of the vertex and the presenting part. and then from the cervical dilatation has been seen, and we can give her some more time. Basically, earlier there was a cutoff that 45 minutes is the only amount of time to be waited, but now we can wait for some more time if we feel, after reassessing the pelvis and the fetal presentation part and the applied head properly, we can give her some more time and allow her to progress. But high forceps and high vacuum is contraindicated. If not, if you think she's not going to progress, you can post her for section, depending on our reassessment, and plan for an LSES in the second stage.
So before we go to cesarean section, I want to ask Dr. Gitendra Sharma sir, 20-25 years back, sometimes there was a trend to first apply vacuum, bring the head down, do a forceps delivery, bring out a battered baby with all sorts of neonatal compromise to avoid cesarean section. Do you think that is any more justifiable in 2020? Should people be trying for obstructed labor to deliver vaginally with an instrumental delivery?
Absolutely not. It is not recommended in the era of consumerism. And see, counseling is must. And one thing I will like to mention here, that we have to see the uterine contractions also simultaneously. So if they are not good, then we can stimulate the uterine contraction to help the delivery. If pelvis is adequate and on monitoring fetus is good. Legally, you should not do that, because nowhere it is mentioned in book, as far as textbook is concerned, that you should take the baby down with the vacuum and then to apply forceps. So these ventures are nowadays not advisable.
Today it is safe mother, safe baby, sir. So no risk at all for the mother or the baby. So and for the gynecologist too.
Message to go out to everybody that while instrumental deliveries still have a place in modern obstetrics, these foolhardy ventures in textbook deep transverse arrest are not pardonable. Even if you successfully deliver the baby, that would be something extremely foolhardy. Dr. Aruna Suman wanted to say something. Please go ahead.
Yes, sir. Here we have a case something like this. We have been using the partograph. We have to think about 3 P's. One is power, that is uterine action, as Dr. Gitendra sir said, and the other is passage. To feto-pelvic assessment should be done again if it is a big baby, and how is the pelvic capacity. This is more important. And the other is the passenger, which is also important. And we have to exclude the CPD, and then only we have to start syntocinon and monitor, and we can actually wait in this patient.
Thank you. I think these are very important points.
Add one thing, that in the case we do not know the status of the membrane, so if that is the situation and it's not progressing adequately, definitely at that point of time amniotomy, if not already done, obviously would be one of the things. And the second very important thing over here is 45 minutes, I think we can wait on, and nowadays in a primary we can wait up to 2 to 3 hours is what it's actually recommended. So we can actually wait on and see. But the thing is, depends again on the diagnosis. If it's a deep transverse arrest, obviously there's no point of waiting on and taking out a battered baby. And as Rekha ma'am has correctly pointed out, I would just like to add one thing. You said that safe baby and safe mother. I would also say safe doctor, because in today's day, at the end of the day, that is also very important.
So
but
Dr.
now,
Rekha, yes ma'am, go ahead.
the role of intrapartum ultrasound, if we have in the labor room, has increased. So I wanted to bring this out because people, if they have an ultrasound which can be shifted, reassessed, and done it safely, because repeated PVs patients don't like, and they're very fussy. And again, for us also, it's very difficult. So if we reassess with an ultrasound, it's evidence-based again. We have documentation.
And sometimes you might diagnose a cord around neck because you did an ultrasound and you had missed it in the third trimester ultrasound.
So I
that
think
is also
there is a
another
role
reason.
for intrapartum ultrasound now, sir.
Thank you. Since we are with you, I would like to ask you,
yes, sir.
What are the points that you will keep in mind when you're doing a cesarean for this patient? Doing a routine cesarean is different from doing a cesarean for a patient whose head is stuck deep in the pelvis. And how would you take care to ensure that this baby is delivered safely without trauma to both the mother as well as to the baby?
So in this baby, earlier they used to try, pushing the head from below and then delivering. I think we're out of it, where we are worried about the infections to the mother and the baby and the intrauterine infection. So you can do breech delivery from above. maybe Patwardhan's method, or you can have a vectus to elevate the head and bring it out and then deliver the baby. So pushing it from below and all is an old concept, and which we shouldn't try now. This is what we do when we do have these kind of
So
cases.
there are 2 points which you mentioned. One is a vaginal assistant trying to push up the baby's head. The second is maybe a modified Patwardhan maneuver. And the third is a vectis. I think vectis would be difficult to apply
If
because
it's
the
not
head
very
is
low,
already
sir,
stuck.
you can use a vectus.
Yeah. Priyankur, you wanted to add something?
Yeah, sir. So just simple, like when we are taking an incision, the incision has to be little on the higher side, because sometimes it's noted that when we take an incision and take it in the thinking it's a normal lower uterine segment, sometimes it's through the bladder or sometimes even in the vagina, which becomes very difficult to suture later on. So take it a little higher up. The catheter should be in place, and of course, depending on, of course, it's usually a little bit of blood tinged urine that comes out in this sort of stuck labors basically. So that could be one of the things, and then obviously a little higher up incision, and then of course
We are unable to hear you. I think there are some internet
Patwardhan is
issues.
one of the things that should be tried, but then it should be in a doing a Patwardhan also we try to our causes trauma to the baby. Can't be okay.
I'm going to ask Dr. Pradnya Changede,
Yes.
any tips that you can give us, madam, regarding the delivery of the baby with a deep transverse arrest? Would you like to have a senior present? Would you like the best person on the team to be the one who is operating? Any other tips and tricks that you can give us?
The one thing, sir, I would like to mention is correct diagnosis. So many times, because there is a lot of caput, you feel that the station is low. Whereas, you have to always remember station is the bony part, and it is not the edematous scalp which comes down. This is where most of the obstetricians fail to judge the station, and they apply instruments, which causes fornical tears or broad ligament hematomas. So to prevent this, one should always remember and train yourself that station is going to be the bony projection, so it is quite higher. Secondly, of course, if you're giving trial, you have to ensure, suppose you're waiting, since it is just 45 minutes, senior should deliver this baby either vaginally or by C-section. You can have a long anterior rotation or a face to pubis delivery, even in this type of case. Suppose you have good contractions, but it is going to be a prolonged labor and you have to be ready. Also, even if the baby manages, you may manage to deliver, there's a chance of postpartum hemorrhage in this case, wherein, the labor is going to be prolonged and you have done a lot of vaginal examinations. So one has to be ready for all
Thank you.
these.
I'll just leave you with a couple of papers which I found interesting on the topic. These are only of historical interest, and they are just for educational value. This is a paper which was published way back in 1993 regarding the mode of delivery. This is from an Indian institution, actually from PGI Chandigarh, where they looked at how evolution of deep transverse arrest delivery took place over 10, 20, 30 years. And they looked at their data, and in 1970, almost 45% of the deliveries were being conducted by Keeland forceps. I don't know how many of you have actually seen this instrument, leave alone actually having used it. We have seen it once upon a time, but honestly, I have never used it in my own practice. Manual rotation forceps were very much in vogue in that era. And of course, over a period of time, this has died away, and this is only left to our textbooks and to museums. This is a picture, and I have to credit our past president of Foxy, Dr. Shyam Desai, for sharing this picture with us when he and Dr. Shirish Daftari had gone to the RCOG museum. They came across this display of all the obstetric forceps which are commonly in use once upon a time, and they were very kind to share this picture with us. I think this should be part of all our teaching, that there are obstetric forceps which are still available. They have a certain role to play, but this is not the time and the place to use them. I think we are running out of time. We'll just do one last case before we close this discussion. This is a 25-year-old spontaneous pregnancy, recently moved to a small town from a village, presented in active labor, 4 centimeters dilated. She has previously been batted, as we call in Mumbai, from a smaller hospital or a private hospital and sent to a government hospital. She is referred to you. Her antenatal card shows HIV recheck status. What are the implications of this HIV recheck status, and what precautions are you going to take, Dr. Rekha, when you deliver this woman? She's probably going to deliver vaginally because she's in active labor, already 4 centimeters. But what is this HIV recheck status? What does it actually mean?
She might have been positive or discontinued medicine, or she might have been a contact. So
Absolutely.
we don't know what is her present status. So ideally what we would do is get the investigations done again. We will take universal precautions for this patient, and if we are delivering her, we will not do an early ARM, allow her to get into spontaneous labor and progress naturally. And we will probably also not augment. We will wait patiently for her to set into active labor and deliver, and we will do an early cord clamping for this patient. And if she's not, at least if she has taken 3 months of medication, we have to, counseling plays a very important role for the mother and the child, and we also have to counsel them that the vertical transmission rate is high if she has not been on medication. And
yes, she is in active labor. This is not the time and place probably to counsel her.
No,
we would probably do a detailed counseling session
also
after she has delivered.
Yeah.
But from the point of view of preventing vertical transmission to the baby during labor and delivery, are there any medications that we could administer?
They give nevirapine, no sir. They give us dose of nevirapine.
The latest NACO guidelines give a triple drug regimen, what we usually give to all our patients. So it is lamivudine, you get efavirenase, and you give tenofovir. So it's a triple drug combination. So even if the patient comes in labor, you have to give this triple drug, provided you confirm her HIV status.
Thank you, ma'am. I think that is well said. If you look at the most recent updated NACO guidelines, which are there on the Ministry of Health and Family Welfare website, updated in 2018, they clearly tell you about the regimens that antenatal pregnant women should be given, as well as for women who are already in labor, may or may not have been diagnosed earlier, and where you need to take universal precautions. There is an entire cascade that follows once a patient is antenatally diagnosed. We are not going to discuss that here. Here we are only talking about patients who have presented directly in labor. Maybe they have been scared, they have not taken treatment, they have run away, and maybe they have been battered from whichever private hospital they have gone to, and they'll end up in a general hospital or a district hospital where they have to be tackled by people like you and me. So this is what is the antiretroviral therapy, which is recommended in labor. And as you rightly pointed out, Rekha ma'am, that the child has to be administered nevirapine, and ideally this should be for at least 12 weeks, especially if the mother has not received ART during the antenatal period. Can you tell us something about the follow-up of this baby post-delivery? What would you recommend?
So actually, at least 24 weeks of ART, then you can give for 6 weeks. If it is less than 24 weeks of ART, then the recommendation is 12 weeks of nevirapine.
So as you can see, if there has not been any ARV given previously and you breastfeed the baby, the risk of transmission is as high as 45%. But if you give even one dose and you withhold breastfeeding, then you can reduce this by a significant amount, and this should not be denied to the patient even if she is not received antiretroviral therapy in the antenatal period. This is an obstetric emergency of modern times. In the old days, we used to always consider bleeding placenta previa, abruptio placentae, eclampsia as one of the obstetric emergencies. This is a novel emergency which we are now seeing today because we live in different times compared to when our textbooks were written. And there are 5 do's for infants at 6 weeks according to the NACO guidelines. Do continue the reinforcement for exclusive breastfeeding. Perform your testing at 6 weeks. Do immunization as recommended. Make sure that you initiate therapy until the baby is at least 18 months old. And after 6 weeks, you are supposed to stop the nevirapine prophylaxis and switch after you've handed over to the pediatrician. I think we have reached the end of our panel discussion. It's 4:30. I would like to close by thanking all of my eminent panelists who joined in today. And I'll remind the viewers that all of us have knowledge. Unfortunately, sometimes because we are in emotional distress or we are scared because of fear factor, we don't use our superpowers. Our superpowers are that we can apply the knowledge that we have, and that is what brings us success. There are 675 people logged in today for today's webinar. So I'd like to congratulate all of our panelists, all the speakers, and I'll ask for just one closing remark from each of our panelists, which they would like to give as a take-home message for all the audience. We'll start with Dr. Ritu Sinha. I think she's come back from a delivery just now. You joined us just in time, ma'am. Any take-home messages for the audience? Please unmute yourself.
Yes, sir. You have not taken up the last case scenario, I think, sir. So I have landed up in the same situation, previous to cesarean with twins, MCDA twins at 34 weeks. Oh, so I did it. So thank you so much, sir. It was a very nice getting attached to you also. Thank you so much, sir.
Thank you. Dr. Rekha Rajesh, any closing remarks, ma'am?
How Pratap sir told us, and the thing, we should not miss our basics, sir. So history taking, documentation, and then having a checklist and following proper protocols is the ideal scenario, be it private or government or a medical college hospital. So basics, if we adhere, I think everything else is going to fall in place.
Dr. Aruna Suman, ma'am.
Sir, applying our knowledge on a woman, the patient, is very, very important. As madam said, proper history should be taken, our basics should not be forgotten. Proper clinical examination and diagnosis is very important.
Jitendra Sharma, sir, medico-legal pearls of wisdom from you.
Medico-legally, as Dr. Rekha madam has said, that you have to follow the standard guidelines given in your textbook or journal, or something which is practiced by your peer group, or something which is taught to you in medical colleges by your teachers. And don't try to venture anything in this era of consumerism. And last but not least, in documentation is the only weapon in your hand in the court of law. So whatever you have done should document it properly. So something, if your documentation is good, that will be a good defense. Poor documentation will be poor defense, and no documentation is no defense in the court of law.
Thank you, sir. Thank you so much. Dr. Pradnya Changede, madam.
Sir, I would like to say that anticipation, preparedness, good training, and counseling patient. These are the 4 things that will save.
Thank you so much. Dr. Priyankur Roy, closing remarks from you, sir.
Yeah, there is a lot of adrenaline rush during obstetric emergencies, but keeping a cool head is very, very important. Always remember, safe mother, safe baby, and as I've told before, also safe doctor is the goal that we should aim at.
Thank you very much to all my eminent panelists. As the convener for today's program, it's my proud privilege to present the vote of thanks. At the outset, I'd like to express my gratitude to our President, Dr. Nandita Palshetkar, President of AMOX, Dr. Arun Nayak, our Secretary of AMOX, for always standing by us, supporting us through all our scientific endeavors. Our chairpersons, Dr. Rajendra Singh Pardesi, who is the first Vice President of AMOX, Dr. Archana Verma, Vice President-elect Foxy, Dr. Shashwati Sanyal Chaudhary, who is our past chairperson of Foxy, and Dr. Rajendra Nagarkatti, as I alluded to him earlier, my co-partner in crime, chairperson for the AMOX Midlife Management Committee. We had 2 excellent speakers and 2 brilliant orations from Dr. Amay Purandare, State Coordinator of AMOX, who spoke on RH isoimmunization, and Professor Pratap Kumar. Hats off to you, sir, for your talk on do's and don'ts in prediction of preeclampsia. We rounded off by tackling some common labor room emergencies and looking at how different parts of the country handle this particular emergency in a different fashion. And we had Dr. Jitendra Sharma, our distinguished guest, who is standing for Vice President Foxy West Zone. Thank you so much, sir, for participating in spite of your busy schedule and for giving us your pearls of wisdom. I'd like to place on record my gratitude to our academic partners, Bharat Serums, who through the Bridging Bharat initiative have done more than 100 webinars in the past 3 months, and of course to Science Integra, Subbu, Seshan, Shrimon and Sana, who are our backbone for so many activities and will continue to be in future. We have a total of almost 700 participants who are logged in today. In spite of so many other activities which are happening, there's a Foxy conference which is happening, and there are other events also scheduled on the same day. So I think that's testament to both our speakers, chairpersons, and our eminent faculty who are there as panelists, that they were able to draw such a large audience. Thank you very much, all of you, and we will see you all soon. Thank you and goodbye until next time. Stay safe.
Thank you,
Thank you
Pratik,
so
sir,
much
for the
for
opportunity. Thank you so much. We enjoyed your moderation. Thank you so much, sir. Very good. You brought out all the practical points. Thank you.
Thank you so much, Pratik sir. It was wonderful. Thank you so much for the
Thank you.
opportunity.
Look forward to seeing all of you very soon.
Hopefully,
Absolutely. And Gitan,